getting close. Yeah? Close? No? Close. A lot of shaking of the heads. George, 2 more minutes?
No, 1 minute. Come on. Let's start to rock, guys. We got a lot to do. And
this is what happens when you have, I used to tell, now none of you have done an EP yet, but I tell all of our young guys doing ablations that there's nothing worse than a wounded rhino, okay? I mean, I've been to Africa a couple times.
what?
Well, no, wait a second. A wounded, like you go to the lab and you partially get something.
Oh.
That's what I meant. So either you take it out or you don't do anything. If you wound that pathway, right? You just sit there and like, oh, now it's slow conducting. Where is it? So my close friend George is not a wounded rhino, but he did get. He'll tell you the story. I'm going to let him tell you. So he wants to stay on time. He wants no monkey business. Is that fair?
Yeah, well,
sorta.
Sorry.
Listen, if Dr. Klein and I didn't exchange at least 5 or 6 barbs in a meeting, it isn't worth coming to the meeting. We grew up together at Duke. We went to meetings together. We actually roomed together for almost 20 years because, we'd meet at the meetings and we'd split a room. But anyway, I'm going to fill up a coffee cup and then I'm going to turn the meeting over to George, the first part, which he'll give you kind of an approach, right? The toolkit, George, starting with it. So give me just like 1 second, finish up what you're doing, and then we'll let George go into the toolkit.
okay, guys, I've given you a quick minute, so...
Can we ask one thing, George? Is everybody, how many people are still in their, 3rd year of cardiology fellowship? So majority. There are a couple EPs, right? Just a couple? So just to let you know, they've asked us to sort of position the course for 3rd year cards.
Dumb it down, you mean?
No, but I mean, we're not going to show as primary things complex intracardiac tracings. Right? You didn't put any in.
But maybe a couple.
Take over.
All right. So I just want to say how grateful I am to Medtronic for putting this gig on in particular. I mean, EP in the old days, how many cases a day did we do at Duke when we were doing cases? 1 or 2 at the outside.
Oh.
And then we spent a couple of hours talking to our mentors when we can find them, and our colleagues and so on and so forth. And so we were doing a lot of intellectualizing. Now, the problem with EP is that we've come too damn useful. So everybody's busy. And rounds always take short shrift, I mean, you either cancel them or you come late or the staff guys don't come or you can't come. So the intellectual part of EP, especially the tracings, has really, really suffered. So I say to Medtronic, I'm very grateful to you guys for doing this because I think it's something that we're being lost. We have people here who are doing AF ablation 4 or 5 days a week, and they're not getting any tracing. So tracings are still the heart of EP. So this is my first slide, if you will indulge me with my first slide, and Matt can keep me honest here, since I'm a technical loser here. Okay, not too much philosophy, but just a little bit of approach. First of all, you need to know the rules of the game. You can't play the game unless you know the rules. So the rules, I mean the physiology of what happens when you have a PAC and the AV node decrements, and you have to know the rules, what the behavior widgets you're looking for. So that's a given. The second is, and this is to me my important message, you need to have a game plan when you're looking at a tracing. Like anything else in life, I look at a tracing and I ask myself, what am I going to do to solve this problem? Where do I look? How do I do this? Other people just sort of look at it and they just wait to be inspired by something or wait to see something they recognize in something. That's not the right way to do it. You need to have a game plan. Whenever I get a tracing that's tough or I haven't seen, I ask myself, okay, what am I going to do? So this is where I come in what I just call a diagnostic toolkit that my old buddy Eric always mocks me on, Are you mocking me, boy, again? So,
you mocking me, boy. Ask them if they know where that comes from. Who knows what movie that's from? Are you mocking me? See this, George? You thought they would get the joke. And no one here has ever seen a movie called My Cousin Vinny?
It's a classic.
Are you mocking me?
Pick it out of Netflix. It's a classic, guys. Got nothing else to do, you know. While you're pondering Eric's cases in the toilet, you can watch. You know, sometimes people like to sit there a long time. So, you know, it's nice to have something to, you can read a comic book, you can do other things. So I call it my diagnostic toolkit. And I think of them as mechanical tools, which are very, very simple, and cognitive tools. My mechanical tools are like you see now. I'm using a slide. I don't look at anything complicated on paper anymore, because if I scan it, I've got calipers, electronic calipers. I can enlarge. I can put things side by side. They're important. Sometimes you see things when you do that you just don't see. Now, Eric might see them, Ken might see them, but you know, we've been doing it for a hell of a long time, all right? So you guys want to plan, and whatever little thing you do to help you out is useful to you. And so that I'm not going to give you a detailed list of my so-called tools, but you'll see them become apparent with a thinking process, all right? So I'm going to emphasize wide complex tachycardia. I don't know, and there's going to be a lot of redundancy, all right? And some of it might be tough for you guys, but think about it as a way of thinking rather than learning a bunch of facts, all right? If you learn a way of thinking about it, you'll do well. So when we have a wide QRS tachycardia, I put it into 3 categories. A, I have a nice 12-lead ECG, all right? That's one scenario. The second scenario is I've only got a rhythm strip, and sometimes they're pretty shitty rhythm strips. You know, you get this thing from some other hospital, and some guy's standing on his head and it's sideways and it's distorted, and you're trying to sort out what the hell's going on. You know, he can't even give you the decency to photograph it straight. And then the third category is a wide QRS tachycardia during atrial fibrillation. That's another typical scenario that you have to deal with. All right? So I'm going to try to deal with an approach to those 3 scenarios, and I'm going to try to meld in my philosophy of having a game plan. And of course, Eric will do the physiologic approach because he's very much into physiology, and you have to be into the physiology. If you don't know the rules of the widgets, you don't know how they're going to align. So we move on, and I want you to think about this as a multiple choice question. And I want you to answer the question. I'm not going to give you a long time, but are we ready there, guys there in the back there? Matt's ready. He's all ready. This is the first choice out of 3. So VT, aberrancy, or pre-excitation. All right? Just look at it, and then we'll talk about it, and we'll give you a minute. Oh yeah, sorry. These things are divided into sections. You know, EP, I tell you something, EP is very much a team game, all right? It's one thing you have to learn. When I was in the lab and I was having trouble, or I didn't understand something, or I couldn't do something, but the first thing I did was I hollered for my buddies, all right? And so it's a team game. So it's okay to sort of chitter-chatter around the table, okay? I mean, you might see somebody on your left who's smarter than you, and you might learn something, or you might have a dumbass, in which case you ignore them, okay? All right, so what do we have here? What was my first one? VT. Now, I'd like someone to tell me why they chose VT. Now, this is a smart-looking table here. Why did you choose VT? Anybody? I'm asking, am I putting you on the spot here? Or you?
So we thought the access was kind of a northwest access. We didn't see any, we didn't talk specifically about this, but I didn't see any clear evidence of like AV dissociation. There's some specific criteria we could use for that concordance that I don't think this meets technically. We also didn't, there's like specific things like the R-wave peak time, things like that, I don't think this fulfills either.
Okay.
I think we thought based on the access.
So all you guys thought it was VT, okay? more or less other people sort of did something along the same line, thinking about it, okay? So I'm going to try to teach you a different way of looking at it, all right? There's a wide QRS tachycardia, and Eric and I have taught this for years. Stuck it in our book somewhere, one of the books. And this is a way of looking at the problem, not just fishing criteria out of your brain. What the hell criteria was that? Was it this?
So
What?
I'm
That was
gonna jump
20
in.
milliseconds or 40 milliseconds?
George, can I jump in and tell them a funny anecdote on this?
Sure.
We were writing our first textbook, and this just shows you the difference in two good buddies. One of the sections I was supposed to put in was, how to differentiate the YQRS. I wrote like 2 or 3 pages about all these different rules and different things, and I thought I was being uber academic. So my laconic buddy George writes me back. I'll never forget this. Like 2 sentences, he goes, "Eric, why can't we just say, if it looks like a classic left bundle, it's aberrancy. If it looks like a classic right bundle, it's aberrancy, and everything else is VT." And after this, like 3 pages, taking me like a week and a half to write, and I wrote him back and I said, "Yeah, I guess that's what I said." So that was actually what you did.
That's the bottom line. Eric can get to the bottom line if he wants to. So these are the determinants of QRS morphology. By the way, these are the 7 differential diagnoses that you think about with a wide QRS tachycardia. This is one of these widgets that you just have to know. If I have a wide QRS tachycardia, it's going to be one of these 7 things. And in general, it's the top 3, and in fact, even the top 2 that you're distinguishing most of the time. So you have to know that. Now, the other thing to look at is when you're talking about all these criteria, Shmugata or whatever is criteria du jour, then basically what you're telling yourself is that, for instance, why is northwest axis a criterion? Why is northwest axis a criterion? In other words, he's talking about northwest axis, and he's right, and the axis is northwest axis, means it's in the northwest. Why is that a criterion?
Because it's not the normal vector of the depolarization.
Because it's very unusual to see it in a bundle branch block, all right? It's just not there, so that's why it's VT. So if you just merely ask yourself, the problem is that you've got bundle branch block, and you've got VT, and you've got VT that sort of mimics the bundle branch block depending on where it is. So you're asking yourself the question, how close does this mimic the bundle branch block? If the answer is, holy mackerel, that's a pretty classical bundle branch block, then what are you going to say? You're not going to say it's VT. You're going to say there's a high probability that's VT, all right? So any morphological cryan is fallible, and it is probabilistic. And the only thing you really have to know is, what is a typical right bundle and left bundle? What do they look like? So when you're reading ECGs or you're seeing patients' ECGs, sort of keep a little template in your brain of what the right bundles look like and the left bundles look like, so you can make a comparison, all right? Now, scar is a major influence. You've got cardiomyopathy, you've got people with 16 infarcts, and they've got three fibers left that are contracting. Then you're not going to expect entirely normal morphology. So that's a limitation. Also, sometimes for some reasons that are not clear to me, if you have very rapid rates, like a flutter with 1-to-1, you're going to get really screwy aberration patterns that are hard to explain. So you get into cycle lengths of 200 or 300 beats per minute, these rules aren't as good as they otherwise would be, all right? And the sinus rhythm ECG is very valuable. Now, why do I say that? Because if I'm looking at a sinus rhythm that's pretty normal, then I'm expecting normal bundle branch block, huh? If I look at a sinus rhythm that's totally foobarred, then I'm not expecting terribly useful the morphologic criteria. So that's really the only important principle, as Eric summarized. And this is what happens with the bundle branch block. Typical right bundle is easy. Typical left bundle is easy. And the other thing you have to know is that the first part of the human heart that's activated is the left septum, all right? It's a branch of the left bundle. That's an important factor, and I'll show you why that's an important factor. Before we do that, I want to introduce the concept to you of unipolar electrograms, intrinsic and intrinsicoid deflection, all right? Look at this dot here. That's a site. There's a wave of depolarization, and this is your unipolar electrode with an indifferent electrode somewhere else. As this wave comes to your electrode, it rises, and then it goes, boom, changes direction, and goes the other way. So it has directionality. The unipolar electrogram has directionality. So this is the intrinsic deflection. Now, the precordial leads are ECG leads that are like unipolar leads, because there's one lead and then there's an indifferent electrode somewhere else, okay? So when you have V1, V2, you're looking at the right ventricle. So you know what's happening with the right ventricle, and as it goes around to V5, V6, you're looking at the left ventricle, all right? So that's another important thing to know. So think of the precordial leads as important unipolar electrograms, and that's important to me. So this is the way it looks. The V1 and V2 are looking at mainly the right ventricle, and then septum, and then the left ventricle. So if there's a right bundle branch block, the activation is still going to go early here in the septal branch. So, and something like V6 rather, is still going to look the same. So the initial forces are going to look the same, because the first 30, 40 milliseconds or a little bit of the electrogram is because of the activation of the left septal branch and the left bundle branch, okay? So that's an important concept. So I'm going to show you a bunch of right bundles, all right? Now this is a classical right bundle branch block. This is a Marriott classic. Some of you may know who Marriott was. Others won't. So this is a classic rabbit ear from Marriott's rabbit ear that you all learn in medical school, I think. I don't know what the hell you learn in medical school these days. But there's an RSR prime, okay? That's classical. That's more variable, right? Because we've all seen right bundle with difference. So it's classical, but it's not always there. The other classical thing is this little dip here at the end in lead 1, which is a lateral-looking lead. So that just means that the impulse is activating the right ventricle late, all right? So the initial forces are there, and then the right ventricle gets activated late because it's right bundle branch block, and hence you have the initial forces are the same as in sinus rhythm, but then you have a dip. And V5 and V6, V3, 4, 5, and 6 that look at the left ventricle will also have the same initial forces, all right? So this is a right bundle branch block, which then shows you that if I draw a straight line at the beginning of the QRS, what do I see? I see a very rapid, steep unipolar electrogram, all right? That would be the same as it would be in sinus rhythm. And just to show you, the V1 here is no longer Marriott's classic rabbit ears. One rabbit ear is smaller than the other. It's kind of monomorphic. So this might be a Marriott VTAC. But if we take a line and we look at the initial forces, they're very rapid. So the left ventricle is still, the first 40, 60 milliseconds that the left ventricular leads are looking at are the same, all right? And then we look at that, same scoop. And here is one where we happen to get a normal beat and a right bundle, and you'll see that the initial forces are exactly identical, with the difference only being this little hooky, this whatever little sagging thing here at the end, which activates late of the right bundle, okay? So if we contrast this with this is a sort of a right bundle. We look at, this is a PVC, okay? And this is the normal beat. You can see that there's a PVC and a normal beat. The normal beat, look where that line is. Its initial forces are the same. Look what happens with the PVC, huh? It's not straight up, and it's far away, and it just doesn't look like it, right? The initial forces are not the same, and there's nothing to memorize. All you got to know is what the hell the right bundle does, all right? And there are 50 criteria you can derive from that. And more of the same, guys, okay? Another species of right bundle, and it's the same thing, all right? So the initial forces are the same. Well, how about a left bundle? This is a classical left bundle, okay? And what is classical about it? Well, you know, they get the RSR prime in lead 1 and V5 here. Sometimes it's monomorphic. It's a little more variable. But what this is more constant is that you're looking at the right ventricular leads, and what do the right ventricular leads see? But they see the initial tiny R, maybe, V1, V2, 3, but then the rest of it scoots way over to the left, okay? As it's going slowly to the right, but it's scooting over to the left, gets into the His-Purkinje system. So you're going to see something straight down almost, like a suicidal ski run that I survived before I got walloped by somebody. So very sharp, almost a straight line, all right? That's a classical left bundle branch block. And V1 to 3 are my go-to leads that are the most reliable. All right? And I bring you back to this. If it's left bundle branch block and the right bundle gets activated first, you're going to get a little bit of positivity in that V lead, and then it's going to go that way. All right? And it's going to give you that very rapid going away. Because it's a unipolar electrogram, if it's negative, it's going away, all right? If this were an intracardiac electrogram, then you'd say, my electrode, is it very close or very far from an early site of ventricular activation? You'd say it's very early, right? Because it's very near the 0 point, right? So that's the way it is. You've got a rapid unipolar. Unipolars are very valuable if your lab is able to do them properly. They're sometimes a little finicky. All right, so a few examples of a left. Just have a look. I've drawn a line for you. You can do this yourself just when you're reading routine ECGs. Different, little bit variability here, there. By the way, just as a little widget of knowledge, what's this guy? PVC or PAC or what? Let's say you had a wide QRS tachycardia that looked like that in this patient. What do you think? A rhetorical question. I'm not going to nail anybody for that, all right? But this is a PVC. And the reason it's a PVC, there are two reasons. One reason is that there's no P wave in front of it. And the PACs usually have a P wave in front of it. I'm comparing, and this is one of my tools, if you want to look at it that way. I look at this nice, clean QRS T wave, QRS T wave, QRS T wave. Out of the blue, this thing comes in. There's no P wave in front of it. So it's not a PVC because it's wide, which is what 98% of people will tell me, and they're wrong. It's because there's no P wave in front of it, all right? The second reason is that you've already got a baseline left bundle. So the second little widget rule is that if you've got a baseline left bundle, anything that you see after that that's different than that is almost probably VT. You can take it to the bank. Now, there might be exceptions, but you've got a left bundle, and if you get, what kind of aberrancy you're going to get? If you knock off the right bundle, you've got nothing now, right? So just take that as a widget that's reliable probably over 95% of the time, I would say. I don't think I remember seeing one exception to that. So that's a widget, physiological, it's a rule. You just have to know stuff like that. Is this a typical or a non-typical left bundle? Typical, all right? It's V1, V2, V3 is a little bit down, okay? Now, guys, so there's going to be redundancy. And to be quite honest with you, I'm not sitting here, actually sitting holier than thou because I'm a dumbass too. It takes me a long time to learn something. And sometimes I have to see something 5 times before it goes into my feeble brain. And then I'm relearning stuff I used to know before, but then I've forgotten. So that's the way it is. You got to be humble because if you're not humble, you just don't get it. All right? So now let's go back to the guy who was spouting Shmugada criteria. Are you looking at this different now? What are you asking yourself when you look at this? You see a wide QRS tachycardia. Now, everybody's looking for P waves, and that's great if you can get them, but most of the time you don't get them, all right? Most of the time you either can't be sure or it's too fast, or you just don't see them, all right? So what are you thinking? What are you thinking about? It's like a language commercial a few years ago where there's some guy in Norway who's a dispatcher, and there's a ship calling Mayday, Mayday, I'm thinking. So the guy goes, yes, what are you thinking about? So it's supposed to be for the language school that's teach this guy proper English. So
I don't know that we got that ad in the United States.
it was actually a German ad.
I know for sure we didn't get it in the United States.
Okay, so what are you thinking about now when you look at it? You see, I don't have any P waves. Okay, that's nice. There may be some P waves there, but nothing I can hang my hat on, right? So now I'm looking at this morphology, and is it sort of a right bundle or a left? Right. Now you're asking yourself, is that a typical right, or is it not a typical? Now, why is it not a typical right? Look at the lateral leads. Look at V4, 5, and 6. And see, look where the rapid deflection is. It's way over into the middle, huh? That's a VT morphology, all right? And I will tell you that that's true with probably 95% certainty, all right? And I gotta remind you that the QRS is probabilistic. There's always, maybe somebody's got this deranged heart or something, or cardiomyopathic with 3 fibers left or something, so there's always atypicality. So you're making a probabilistic statement when you use the QRS. All right? Contrast it to this one now. What are you going to say? What's your strategy besides, and you're not going to bring up Shmugata criteria or the latest thing you've read. All right? What's your strategy? It's sort of a right bundle, right? Is it a typical right bundle or not? The initial forces are very fast and sharp, identical. So because it's going through the left septal branch and the left ventricle sees the same thing it would if it weren't right bundle for the first 40 milliseconds, all right? This is all you have to know about morphological criteria for VT. You take any criterion published in literature and, you know, it can boil down to the fact that the reason you see this is because it's atypical. So this is another case that's more of an EP 101 or an arrhythmia 101. So you see, I'm trying to teach you guys strategy rather than individual things. Once you figure that out, if you know wide QRS tachycardia, well, that's half of what they consult us for, you know, for aside from AF ablation. So it's important. So have a quick look at this and what is your strategy? And you can have multiple strategies with this, but what would be your answer? Let's take 30 seconds and answer that. It's not too difficult, so I think 30 seconds is enough. And you can actually talk.
You know, you saw the thing for doing your audience response. Did you all get it?
Option A. Okay, pretty good group. Both of you voted for A. That's good. So why would you have picked A? Why would you have picked A? Anybody? Because you probably saw AB dissociation, okay? And here, this is nice. It's a relatively slow VT, and you see nice P waves, and they're not associated, okay? But there's other ways to skin this cat, and we'll look at them. One of them would be the morphological criteria. If you look at the morphological criteria, and you compare this guy, which is the normal one, to this guy, you see that the initial forces are not the same. So that right bundle is totally atypical, all right? How about, this is another tool, a mental widget that I use, all right? What is the most valuable part of the tracing when you're trying to sort out a tachycardia? What is the most valuable part of the tracing? The onset. The onset. Probably second most important is the offset, right? When you get Rita Holter for somebody and the tech runs off 15 pages of the middle and doesn't give you the beginning, then you feel like pulling your hair out. Now, I can't do that anymore because I cut it too short. But it is annoying that they don't know that. That's the most valuable part of the tracing. So do we have an onset here? I think, what about this? P, QRS, and then what happens here? P, what happens? What is this? What happens? P, and then what happens? There's a QRS, but it's too early, all right? That's not conducted. It's too early to be conducted. And what is this beat called in the jargon? The F word, exactly. The EP F word, all right? It's a fusion beat, all right? Now, you don't call things a fusion beat until after you've made that diagnosis, because once you start to call something fusion, then you're thinking VT, right? And you don't want to turn off your brain too quickly until you've looked at the data, all right? My biggest screw-ups and mistakes, publicly made at times, is I make up my mind, I look at something with Prstowski or Alan Bogan show something tough. I make up my mind, oh, I know what it is. And then he asked me to talk about it, and I'm totally out to lunch because I looked at one thing and I made up my mind. I didn't look at the other stuff. So keep your mind open, and it ain't over till the fat lady sings, okay? So what other points can be made about this? It starts, this is important. The onset is the important. See how it starts. Another incidental observation, which is kind of cool here, those of you who want to know a little physiology, this is VT, and there's, what do you think about this P wave compared to that P wave, the sinus P wave? It's upside down, all right? So what do you think that beat is? What do you think this beat is? It's an echo beat, all right? So it goes up the ventricle, probably up the AV node, retrogradely, comes back, and then there's no way for it to get back over an AV nodal fast pathway in this particular, so there's no AV node reentry, but you've got a long PR interval. So the last beat of the tachycardia, if this tachycardia would have stopped in the beat before without that retrograde P wave, you wouldn't have had that guy in there, all right? So it's an echo beat. Now that's just a little bit of gravy for that particular tracing. If I give you the algorithm du jour, just pick, I know some of these people are good people, no problem, but just to show you, this is one surefire, you read one every year, I mean, as an editor, you see them all the time, everybody has their algorithm du jour, they're reinventing the wheel after 50 years.
But note how many authors there are on this algorithm.
More authors than cases.
Exactly. That's always a problem when you have more authors than your bottom line.
So here it is. They need at least one. That's pretty good. Monophasic R and AVR, which is northwest axis. That's a big deal, and that's nothing new. Predominantly negative QRS in leads 1, 2, and 3. Well, we don't have that in ours. And all 3 inferior leads and the other leads are discordant. So what that means is that this guy, the 1 and L are negative, and all the inferior leads are positive. So that's a VT criterion. So he would have called this VT by his morphological criteria, all right? You would have called it VT just by looking at V5 and V6 and saying that this is just not a right bundle branch block aberration pattern, okay? And then you have other things to talk about. So that's what I call the criteria method. And I can tell you that I hardly ever talk to cardiology residents or early EP fellows when they don't come up with some Shmugada criteria or something. They don't understand. I mean, you want to be replaced by a computer program or a widget or some dumbass there with a computer screen, or do you want to be a doctor and sort of sort things out? If you're a doctor, EP, you're asking yourself why, all right? And I just call that the cognitive method. Okay, so we will move on. All right. This is an interesting tidbit, and I'll just fly this by you. Is that 30 seconds time I have left, Eric, or not?
Yeah, but we started. How much more time do you need?
I don't know, 5 or 10 minutes. You can take it off my next talk.
That's okay. We started. Could you put 9.5 up here? We did from Canada, and they never had the same currency we do.
Ours isn't doing too badly these days with the petrodollar, huh? So you're trying to shut out Russia, so now Canadian oil looks good again, so that's good. You'd rather buy oil from Russia than Canada, but that's okay. I mean,
Hey, by the way, you can't say anything against Iowa State. I wouldn't say that.
Oh, I know.
Very sensitive.
I know. This is a miscellaneous wide QRS tachycardia, and it's a 33-year-old guy with cystic fibrosis. And to be quite honest with you, I looked at that and looked a little screwy. Somebody called it VT. You look at it, there's not a P wave in front of it. So what's going on here? So it looks kind of screwy. If you look at it a little more closely, then you see, well, what are the initial forces? They're pretty good, all right? So that's okay. So it's going to be, if anything, it's going to be a right bundle. And yet that really screwy right bundle in V1. So what's happening there? Now you put a caliper line at the onset of the QRS, and then you put one at the offset of the QRS, which you see best in lead 1, all right? So now what you see is you've got a QRS duration of 80 milliseconds, and what's all the rest? It's repull, okay? So the little mechanical tools that you're going to use now are nailing the onset and the offset of the QRS. So I call it defining the limits of the QRS, so that you know that the rest is just repull, all right? And that comes out in this one where later in the day they did another ECG, and that looks more like an infarction pattern, all right? But in point of fact, he had myocarditis. This is an infant. I don't know if there's any pediatricians in the crowd? Pediatric EP? They're tough. They can be tough, the pediatric stuff. Anyway, this is an infant, huh? 2-day-old infant. It's my specialty, I mean, it sort of looks like a rabbit.
So George, may I ask you something on that?
Yeah.
Don't you think that QRS is a little wide for an infant? Did they have a bad heart or something?
Did I ask you?
Oh, never mind. Well, I thought maybe you had put the wrong slide in or something. Never mind. Forget what I said.
Okay. Eric, Eric doesn't need any rules because, I mean, to be quite honest with you, there's some advantages of old age and seeing tons of stuff. I mean, you develop a big computer reservoir so you don't have to think about it anymore. But if you look at this, you're looking at this tachycardia, and my first thing is I look at an overview, all right? And what do I see on my overview? I see a regular rhythm. I might put my calipers on it, but I verify that it is regular. I see something here that looks like a P wave and QRS, P, QRS. It's an infant, so it could be just rolling around with a little bit of sinus tach. And then I see this. I call it a transition zone, but anything where something different is happening. So to me, a transition zone is the onset of a tachycardia, the offset of a tachycardia, or where there's something different happening. Maybe a hole in the ECG where you got a few little pause and you see some stuff in the middle. So you see, you have three things here. So what is the key to this? So this is a multiple choice question. Here's your IV drug of choice for termination. Now, this is a board type of question, and it's a board type of question because it's a two-layered question. The first layer is trying to figure out what the hell's going on. The second is, once you figure out what's going on, what are you going to do to treat it? All right? So just answer the question. Just take a second. Well, you guys are fast. Or is it ongoing? It's updating itself. Okay, so I mean, this is certainly worthy of discussion because the drug of choice is going to be, procainamide, all right? Who said procainamide, anybody? Why did you say procaine?
So,
why not amio? Amio is a drug du jour. I mean, my guy in emergency uses it he uses it for measles.
3 was the only one that didn't block the AV node.
Three was the only one that didn't block the what?
The AV node.
Oh, he's using test sat. He doesn't think it's AV node dependent, so he's picking something that doesn't block the AV node.
Yeah, but who cares if it blocks the AV node?
I think I think there's a pathway.
Yeah. See, when you have a pathway, look, I'm going to say this about pathways, all right? The WPW thing. If you have AFib with a rapid rate over the accessory pathway, let's say it's going 300 beats per minute and they're all pre-excited, and you give something like adenosine. Why is that a bad idea?
Because you don't break the circuit. AFib is still going AFib, and it's going to conduct over the accessory pathway.
Right. It's not a good idea because the mechanism of tachycardia is atrial fibrillation going down an accessory pathway with a lickety-split refractory period. So if you look at some medical books, they'll say that the reason you don't give verapamil or adenosine to stuff like that is because you're blocking the AV node. So I ask you, what is the AV node doing during this atrial fib going to 300 beats per minute down the accessory pathway? What's the AV node doing? The AV node is doing nothing. It's watching the traffic go by. So what is the point? What is the difference when you block the AV node or not? It means nothing. So the reason that adenosine is not a good idea, because it might drop the blood pressure a little bit, and it's entirely useless for the mechanism, which is the same with verapamil or anything like that. So in a rapid pre-excited tachycardia, the reason that stuff like verapamil and diltiazem are a bad idea is because they don't have anything to do with the mechanism of tachycardia, and yet they might drop the blood pressure for other reasons, okay? So if you're thinking physiologically, you will read that piece in your medical book where you read it and say, well, that's bloody absurd. That doesn't make any sense, does it? So you think electrophysiologically. Anybody who tells me that it's because the AV node is being blocked has no clue as to what's going on. Now you do, okay?
But George, it is important to understand the hemodynamics. So drugs are vasodilators, and they increase sympathetic tone, and increased sympathetic tone leads to faster conduction over the accessory pathway. So.
Exactly. Exactly. So you're not doing anything to the mechanism, if anything, making everything worse. All right? But it's got nothing to do with the AV node. All right? I don't know whoever dreamed that up, but whoever dreamed that up a long time ago, it's never gotten out of the literature.
That's true. I think for their sake, though, from boards and stuff, it's still contraindicated, but not because of what you may have thought of the AV node, like Dr. Klein said, but because of what Ken's saying. You can vasodilate, you can make them go faster for a different reason. But I mean, if the board question is which drug is contraindicated in pre-excited AFib,
absolutely.
Yeah, but they need to know. I want to make sure they knew that distinction.
The distinction. I'm talking about well, you can also say that nitroglycerin is contraindicated. Why? Because it's got nothing to do with anything, and it might drop the blood pressure. All right? So let's get back to this before I digress. You know, we all have our little buttons. And Eric has his, I have mine.
I definitely have buttons.
Whenever somebody says that, I say, oh, God, is that one still around?
But that is the reason I'm saying is that's a classic board question. So everything Georgia said is spot on. But if you get a question and it says, is verapamil contraindicated?
Yes.
The answer is yes.
If they ask you, why is it contraindicated? Then you're in trouble, because once a guy showed me a board question from some other country, and the board review, and the correct answer was because it blocked a node, and I said, I'm sorry, buddy, you're in trouble here because you have to answer this board question, but on the other hand, the guy who set the question doesn't know his ass from a hole in the ground, so what are you going to do? You're stuck. We all have that situation in life where your boss says something and you're looking up and they say, what have you been smoking, buddy? You know, that's crazy. Okay, so let's get back to this ECG. All right? So we have this ECG, and we have a one-to-one tachycardia, wide open differential diagnosis. And the axis doesn't bother me particular. Eric was troubled by the fact that the QRS is a little wide. And I have to hand it to him, it is. But I think the answer to it is right here, where you got these little pauses in the action, all right? So you have a QRS and a nice little retrograde P, and then you have this. What does that just remind you of that we just saw? We saw the echo, right? It could be a retrograde QRS and then an echo. Now, the other thing, too, is that this QRS is early, all right? So what I do at first is I enlarge my tracing, and I stretch it out so I can see a little easier. All right? That's a mechanical tool. That's why I like to look at them on my screen rather than on the paper. And so when I have my calipers, and I bring out, put each caliper on the QRS, and that's my rhythm. It's nice and regular. And I put this here, and I see QRS. That's early. So the V is early, and it also sucks the A in with it. All right? So what does that tell me? The V is the first one to move, and it sucks in the A with it. It tells me it can't be an atrial tachycardia, all right? Because if it were atrial tachycardia, then the early V would not suck in the A, all right? The other thing I would look at, and this is a concept that's very important, and you will hear about it again and again, but it's the concept of reset, all right? So I got 2 beats here, and I've got 2 beats here. And what has it done to the tachycardia? It's done nothing. So that stuff in the middle did not reset the tachycardia. It didn't alter the timer, which means it didn't have access to the guts of the circuit. That's electrophysiological thinking, that if it doesn't reset, it didn't have access to the guts of the circuit. And that leaves just a few things. So that leaves VT, AVRT versus AVNRT. And this happened to be VT. Eric was right on. He's spot on because he noticed that this, instead of being a narrow QRS tachycardia, it was an infant. Keep your head up. You see that it's just a little wider than the sinus one, although that could be a little fused, but a little wider than this guy. All right? Not much, but a little wider. So this is VT. It's all compatible with VT. If it were AVRT or AV reentrant tachycardia, where is the circuit? All right? It's coming down orthodromic, it's coming down the node and up a pathway and making a big circuit. Is the ventricle part of the circuit? Yes, the ventricle has to be part of the circuit. So if you suck the ventricle in, then that has to reset the tachycardia, with some exceptions that I'm not going to get into. We can do that later, more advanced. But I want to, do you understand the concept of circuits that a reset indicates that you've gotten into the circuit somehow, all right? If you don't reset, you haven't got into the circuit. And why would you not got in the circuit? It's either far away or it's tiny or something like this, all right? Then the options we have, VT, AVRT, AVNRT, then AVRT seems unlikely because you might have expected, if this were orthodromic tachycardia, if a V comes in, you might expect the next A to get a little earlier and just boost the circuit up one, okay? A little bit, all right? So it's only compatible with VT or perhaps AVNRT. This turned out to be VT. And they gave adenosine, and unfortunately, they didn't do anything else after, and I just got this sent to me from somewhere. But it was obviously VT, all right? So you've got to be careful with infants. I have other stuff, but I can begin to do the other part of my VT talk next time my turn is up.
Yeah, do you mind? We can try to stay on time.
Sure. No. So we spent all this time on QRS morphology, all right? So I just want you to walk away with, when you see a wide QRS tachycardia, ask yourself, is it a right bundle or a left bundle? And then look where I asked you to look at, because those are the best places to look, all right? And then you can make a probabilistic statement. You don't have to go looking for somebody's criterion or try to remember 50 criteria that are bullshit because you don't understand why they're that way anyway, right? Okay, so thanks.
Thanks, George. One of the tricks I've employed over the many years I've been doing courses is, as a course person putting it together, and this is really all three of us putting it together, but I always try to pick people that I can learn from. So I've been in tons of courses with George and certainly a bunch with Ken, and there's always some new tidbit I pick up. You know, we all look at things a little differently. You'll look at the same tracing. When George and I have written our books together, you know, I'll send him my tracing, he'll send me his, and you have your explanation in there, and then the other guy says, yeah, but what about that fourth complex? And you say, oh, yeah. So I hope you learned as much as I did from George. He's always entertaining and outstanding. I'm just going to add kind of the second layer to this. So why am I calling it a physiologic approach? It's not a totally different approach than George has taken, but I want you to know some of the, especially since most of you haven't been through EP, some of the underlying electrophysiology you need to know to answer the rest of the course, right? So it builds on what George is saying. And this is from our first textbook. This is how George and I suspect Kenny does the same, look at it. As you get more sophisticated, you should view an electrocardiogram as a His bundle tracing in your mind. One of the reasons that George mentioned sometimes is being older and doing it for 4.5 sort of decades is that you have seen so many examples in the lab that you start to build your own portfolio of what it could be. So when I look at a tracing, I just, in my head, I'm picturing intracardiac electrograms. So what could this be? Different, it's the same sort of approach. It's kind of, but it takes you more from the view that, especially as you'll see with heart blocks and stuff, what's possible. If you don't know what's possible, you're never going to get it right. So we're just going to blitz through some of the rules, and you have all these as a handout. You can look at them in more detail later. I was just talking to Ken. I was saying, you know, this is like a textbook that you put together. I didn't realize how detailed it would be. I thought you were just going to give you some occasional slides, but it's actually pretty cool, George, if you actually page through it. Anyway, some of these are stolen from our textbook. This is from our textbook. Okay, so what I want you to remember here, I don't know, Matt, should I use the pointer here, you think, better? Yeah, you know what, let me sit, because that way, then I think all the screens will see it. Is that what you're saying? Yeah. Okay, so basically, when you look at an ECG, it's got its component parts, right? So the P wave is, as you know, is the activation of the atrium. And then there's the PR interval, but the PR interval is the entire time it takes to get from the P wave to the ventricles, and that includes atrial conduction time, AV node, His Purkinje. So a prolonged PR interval technically could be, if you had a really, really lousy atrial conduction, it could all be in the atrium, okay? You hardly ever see it, but it could be. And then you activate the QRS, right, in green, and then, of course, repolarization. Okay, this is from a classic text from Tawara, which I purchased, I don't know, 55 decades ago or something. I have his original text. And he was one of the first anatomically. There's also something called Tawara's node, which is the AV node. But he early on showed that the left bundle is not a bifascicular system, a la Rosenbaum's, which you won't know, but criteria. He thought it was, your old terms you'll hear, hemiblocks. Los hemiblocks is from Rosenbaum's book. But no one uses that anymore because we know it's not that simple. George was pointing that out in one of his earlier slides. This is actually from his anatomic descriptions. There is a very prominent, and Ken will get into this a lot more when he talks about some of the pacing stuff. There's a very prominent septal activation, and then there's an anterior and posterior fascicle. And if you apply, this is from the old surgical days when we would take people to the OR and map them out. These are blue is late and green is early, and this is an LAD. This is showing you the epicardial activation of the normal sequence in the heart. And normally, remember, you'll break out earlier around what's called area trabecularis, that's the right bundle. I know it's endocardium, but they go fairly quickly to the epicardium if there's no scars. So you have an early breakout here, you have an early breakout here, and you'll have an early breakout where the left posterior fascicle is. You don't see the septum, right? So those are the typical things. Tell me what do you think, what bundle branch is here? Anyone can call it out. Right or left? Blue is late, green is early. Right or left? What's late? Right. This is an epicardial map of somebody who has a right bundle branch block. Now let's see how fast you are in this one. This is left. And that's what happens. George showed a different one, ECG, but it all starts from how the heart's activated, right? So in a left bundle branch block, or delay, whatever, the right's first, then the right gets activated first and the left's later. Then you get all the ECG criteria to fill in. But it's all based on underlying physiology. And make life simple for yourself. Just remember this when we talk about any kind of conduction problems. This is what it is. You start in the atrium, you go to the AV node, you go to the His, and you go down both bundles, and then you branch out. Just remember the physiology, because block can occur anywhere along here, and then you have to learn how to pick those things apart. Also, when you're in your mind's eye, you're looking at how conduction goes. Here's your PR interval, and there's a time it takes to get from the sinus node to the AV node. That's usually about 30 to 40 milliseconds. And you'll see how this comes into play when we talk about heart blocks. There's a time it takes to go from the local AV node area to the His, and that's the so-called AH interval. It's about, in this case, it's 50. It's 35 to 50 is normal. And then you go from the His to the right bundle. That's 10 to 15 milliseconds, and finally to the ventricle. And all those measurements make up the ECG PR interval. And as you're going to see, perturbations of the PR interval can occur anywhere in there. And you've got to learn the rules of how to pick those things apart so you can figure it out. They're not as hard as you might think. So let's go through some abnormal conduction. Here's a person, now this is fast paper speed, and you have all these in your book. This is actually a narrow QRS, but it's very fast paper speed in the lab. And the PR interval is long. And the PR interval is long in this patient because they have a long AH interval. So this is first degree, and so I would like somebody to tell me which beat is blocked. Can somebody point out which beat is blocked? Anybody? This is also from my cousin Vinny. It's a trick question. Remember? I can't answer bullshit question. I can't answer that. They didn't make a so-and-so Ford Chevy. Remember? That's a great scene.
Yeah.
I love that scene. Anyway, is a beat blocked? And please tell me you don't see anyone, no drop beats, right? There's a term, you push a button, there's my button. I've asked anybody who says there's a drop beat to help me find it. You know, let's go on the floor and look around. Now, I had back operation in August. You can see we're getting older. George got smeared, so I had a back operation. You know, we can't be rummaging around the floor looking for all those drop P waves. So please don't use those terms because we're going to be very upset. So so what is this called? First degree? Yeah, thank you. See that, George? Teachable. Some concepts are teachable. And, you know, we tried to get that changed. Once I spoke to people on the ECG committee for the American Heart, and I said, you got to drop this finally. They didn't, of course, because they don't understand. Anyway, we won't get into it. It's the same reason Chad's VASC, right? I mean, I'm off on a tear. So the Chad's VASC, I was on that committee, wrote the first guidelines, okay? We didn't put gender in there because the data did not support it. So then the next two guideline committees later, they come in and they decide to put gender in. And then a couple years later, they realized gender is not supposed to be in there, like we said in 2001. So you think they would actually change Chad's VASC to a new acronym? No, because they like Chad's VASC. So they tell you that Chad's VASC is a 3 for anticoagulation for a woman, but 2 for a man, because gender doesn't matter. Really, George? It's like that German commercial, whatever it was. So anyway, AV conduction delay, thank you. So first degree AV conduction delay in the AV node. Now, PR interval prolongation in a bundle could be either place. I'm happy to show you one in the His-Purkinje system. AV node's normal. But I will tell you there's no way to know. Okay? There's some maneuvers you can do, and we'll get into that when we get further in the course. But if I saw this patient in my office, I would not run him to the lab. I might do some other things. First degree AV conduction delay with a left bundle, a right bundle, any bundle tells you the His-Purkinje system's in jeopardy, but it doesn't tell you where the level of block is. But that's the one you have to at least assume could be below the His, okay? So just keep those concepts in mind. And sometimes you get sort of balance block, right? So this is a person who has a little bit of a right bundle. No big deal if you saw this. PR is lengthy. AH is 10 milliseconds long, but actually the HV is much longer. So like George said, you know, you can do this for 4 or 5 decades, but there's certain things you just can't figure out from an ECG alone. But you need to have in your head the choices. So when you get a bundle and you have a first degree, you know that could be somewhere in the His-Purkinje system. That's the one thing you got to keep in your head. All right, Winky-Bach is pretty simple, right? Just pacing someone in the lab. You all know the 5 criteria for Winky-Bach? I'm sure you don't. Give me one criterion, I should say. Oh, never mind. And I don't have a multiple choice question because I wasn't going to bring it up. So there are criteria. George and I took a very famous course. In fact, I think it was probably, for me, George, one of the best courses I ever took in my life. George and I were fellows together when we were sent to Chicago, here in Chicago, in the dead of winter, terrible, terrible winter, like minus 20 or something. We were, of course, splitting our room together, even as fellows. Of course, then we had to because we didn't have any money. But we took this Pick and Langendorf course. They're both passed away, but it was the absolute best course I ever took. They were geniuses, ECG geniuses. And they would bring you up to the board, and you thought you did everything right. And you're in front of, like George and I are little Pishika fellows at Duke, and they're sitting around chairmen of cardiology, and we're looking at each other like, I don't really want to go up. Ram Tool is in the audience, you know, I don't really want to do this. But they know what your training is. They knew what George and I were doing at Duke. They keep up on things. And they gave me something that I should have known. Did a whole year of sinus node cell work. Wrote a couple papers. And I remember that, George. Pick gives me a sinus node, or I think it was Langendorf. And I thought I just ate through it. I was so proud of myself. And I finished, and he's standing there. He said, "Is that it?" And then, you know, that's when you slink to the floor because you know you really screwed up. And he points out 5 other things. But anyway, they were geniuses. They were the best ever. So, a stable rhythm, okay, progressive prolongation of the PR interval. The initial increase in the PR, first increase is the biggest increase, okay, non-conducted beat, and the time of the pause is less than 2 to 1. Those are the 5 rules of classic Winky-Bach. All right? You can ask me later. I'll tell you. It's not in the book. All right. And then there's the ever kind of SOB one, 2 to 1 block, because it's got its own category. Because you don't have a sudden non-conducted beat, like Mobitz 2, and you don't have a progressive. You got 2 to 1. So you just got to figure it out, right? We'll tell you some of those rules. I will tell you here, this is 2 to 1. You have a bundle. So anytime you have 2 to 1 with a bundle, you need to be worried. Okay, that person needs to be studied. That person could have 2 to 1 block in the AV node or in the His-Purkinje system. If it's in the His-Purkinje system, they need a pacemaker. You can't be screwing around. Now, there are clues here, though. When you have a short PR interval, and if you remember that little quiz we gave you, if you have a normal PR interval, okay, I'm going to tell you it's going to be below the His, as you can see here in the lab. You don't always get it. You can see here because if you just run the times down in your mind, what's the PA, what's the AH, okay, you'll realize if you're sitting at 160 or 70 milliseconds, then you have a normal AV node. You got it. Just play the numbers, right? It's 40 to get to the AV node. I'll give you whatever to get through the AV node, and then you have the His-Purkinje. You only have 160 milliseconds, and I've never personally. I'll ask my buddies here. I've never personally seen 2 to 1 block below the AV node in a normal AV node. Have you, Ken, George? I've never seen it. So you can go to the bank on that one. You got like 100 some odd years of experience here. So if the PR is normal, it's a wide QRS, 2 to 1 block. You can go to the bank. It's in the His-Purkinje. That person needs a pacemaker, okay? So that's how you sort it out. When it's narrow, not so fast. We'll get into that. All right, then you have complete heart block where the P waves have no connection to the R waves. This is narrow, so this was a person who had congenital heart block. The His is in front of each QRS. But, oh, yeah, I'm sorry.
Procedural issue. I got a text from somebody about a question from the other audience. Can somebody help me with that? Who's calling the questions from the audience? Are you doing that?
I texted it to you, yeah.
All right. For me?
Well, because you're smart. The question was, why and how does our interval shortens in Winky Bach?
So the question is to Eric.
Okay. So the question coming from the online audience. I forgot to tell you, there's a couple hundred people watching from all over the world. And by the way, from those from you from Ukraine, you're special, and we love what you're doing, and we're with you. So why does it shorten? You know, that's a great question, and it plagued me until I did something simple. I wasn't sure. You know, I just kept thinking, yeah, I know that's the rule. So I sat down with graph paper one day, and I just graphed it out. And then I said, you stupid idiot, Eric, it's so simple. You know, it's just mathematically. If you look at the first increase is the longest one, and they decrement, you know, after that, they increase, but at a lesser, and you do a graph paper, you'll just see the RRs come in. I mean, it's just math. It's just math. But where that's important, and I'm glad I got the question, is the following. Sometimes you don't have P waves. Sometimes you have like digitoxicity, and you have a junctional rhythm, and you get progressive shortening of the RRs, and then suddenly block progressive shortening. It's even been noted in VT. You'll see, and that's automaticity with Winky-Bach out of the site. So there is a Winky-Bach pattern, progressive shortening, which occurs in other areas, not just the AV node. So it's important to know that. So I'm glad they raised the question. But sometimes you just got to play with things. You know? I mean, it bothered me too until I took a piece of graph paper and figured it out. But it works out. This is a patient who has what you may call Mobitz 2, and often you'll get sent a patient like this, narrow QRS. I know we're going to have other examples, but just to tell you, when you see a prolongation of the PP interval preceding a non-conductive P wave, that's increased vagal tone. There's no reason for there to be a sudden prolongation of the PP interval and heart block at the same point. That has to be extrinsic. These structures in the heart are centimeters away. There's nothing intrinsic that can hit both of them at the identical time. So anytime you see PP lengthen and then block, and it could be a long amount of block, it's vagal induced, and that should direct where you're going. And we're going to come back. We have other tracings, but these are basic rules. Now I want to talk a little bit about retrograde concealed conduction. This is just a little cartoon. If a beat comes down normally, there are certain things that happen. There's a requisite amount of time it takes before anything can happen in the ventricle. That's called the ventricular effective refractory period. Okay? Nothing can get in after that. And then after that, let's say a PVC comes in. If a PVC comes in extremely early and never invades the AV node, it is possible then to have actually a fully interpolated beat. I've seen that once or twice in 4.5 decades. It's rare, and I'll explain why in a second. It's almost always one of these two situations. They almost always invade the AV node, and if it does, it'll leave some wake of refractoriness, and you'll see the next PR interval will be lengthened. Or it gets in so late that the next beat just can't get through. So that's the rules of retrograde concealment. This is typically what you'll see. Here's two sinus beats, and here's a PVC, and the sinus rhythm is just going along its merry way. This PVC will invade the AV node, so this one can't get down, and then the next one comes down. And if you're doing the usual compensatory pause, if you want to do that, 2 times this. Okay, I mean, no, it's this interval here will be a multiple of the preceding interval. If you need to do that, you shouldn't have to do that, but it's a PVC, right? So using Dr. Klein's criteria, does this look anything like this beat? Nothing, right? So it's going to be a PVC every time. Okay, if you have a wide beat, that's what he said. If you have a wide beat to begin with, and then you get a different wide beat, it's got to be coming from a different area, right? It's got to be coming from down below. It can't be coming from above. You already got that. I mean, how are you going to get a right and a left bundle in the same beat? It doesn't happen. Okay. Now, this is the more interesting scenario. And this only occurs at slow rates because you need time for AV node to recover, right? So you'll classically see this at slow rates. And I often ask my fellows to tell me if this is a completely interpolated beat. And they usually say yes, and then we talk about why they made a mistake. And you can see inside the heart, PVC occurs. You didn't get back retrograde, but it came late enough, early enough so that there was time to recover. And then what you see is lengthening of the next AH interval because of the wake of refractoriness from the previous beat. So what does that do to the ECG? It shows you that this interval here is longer than this, and it's longer because the PR is longer. And you don't even have to worry about that. You can just look at this PR and this PR, and this PR is longer, right? Just put your calipers on it. And I know sometimes some people, sometimes the P is on the QRS, so I'll give you a trick. Forget the beginning of the P wave. Look at the end of the P wave to the QRS. Sometimes, that's really the measurement you're looking at, right? The P wave's there, you know that. And sometimes the P is on the T and you're not sure. But this segment will always be there. And this is an incompletely interpolated PVC. You almost never see completely. You'd have to have a rate of like 30 a minute or something, right? For the AV node to totally recover. I think I have 2 cases looking for it in 4.5 decades. So don't count on that. But you'll see this all the time. And the question, if you're on rounds with me, is I'd say, how come this PR is lengthened? That's what I'll just ask you on rounds. And your response is concealed conduction of the preceding beat, which, by the way, we'll get into later, saved Alfred Pick's life. That's a story for later in the course, right, George? Remember that slide he showed? But we'll talk about that later in the course. Saved his life, knowing this one little fact. To be discussed. Okay. This is also in our book I feel bad, Ken's got this and stuff he's written, but what can I tell you? This, I lifted some of these things from our book. You can buy our book if you want. We'll make about 42 cents, or you can ask Medtronic to give it to you, right? You guys who handed out our book? Good. Well, don't give them Ken's, give them ours. I'm kidding. I don't care. We were laughing about it. You write a book, takes you a year to write it, and then you start getting your royalty checks. And honestly, for the amount of time, what's it, like maybe a penny an hour we make or something? I don't know, 20 cents an hour? You don't make money on textbooks. You do that because you want to teach. I can just tell you that. Anyway, you can look at this later. It's just a classification that's practical to go through. How do you look at SVT versus what the rate is? The rates fall apart. So we came up with this classification. We think is more practical at the bedside, and you can look at it at your leisure. And also, there are the rules to differentiate mechanisms of SVT. You have to know what P waves look like, conduction ratios, PR and RP, changes in size. You're going to learn all these during the course, so don't like, oh my God, he's going too fast. I promise you, all this stuff's going to be covered over the course of 2 days. Now, this is an article. If you've not read it, you should read it. It's by Dirk Dorer, is the first author. It is a classic. I make it mandatory reading. Justin. Where you at, Justin? I make this mandatory reading. first journal club we do is the article I'm going to give you. This is, I've read this, George is talking about going back to things. George, I read this article once a year. And I just marvel at the brilliance of the investigators and how hard it was to do this. These are from human hearts, people who died. Dirk Dorer was really one of the giants in electrophysiology. He was the Amsterdam school. And they put in plunge electrodes, and they literally mapped out the entire sequence of normal hearts. And it's a classic. And if you know this, you really study this, like I have for years, it helps you so much figure out patterns, because you know what normal is. This is kind of what, did you want to say? This is kind of what George was saying. You got to know normal before you can figure out abnormal. I'm sorry, go ahead.
So it's required reading also. I think it's an amazing paper. Not only did they do everything by hand, the plunge electrodes, these were like 6 patients who had brain death, and they mapped the epicardial and plunge electrodes endocardial sequence of normal ventricular activation. But they were concerned that people wouldn't believe them. So they had to go to the dog lab, and then they did some dogs to prove that this wasn't an artifact of the way they preserved the hearts. One of the things they had to do is they actually used beeswax to put inside the heart to fix the heart. They were so clever, they figured that out. I mean, it's pretty amazing.
And if you, now you wouldn't know this, but the 3 of us would, if you look at the authors, it's really like a who's who of early champions of our field. I mean, Dirk Dorer, I think Hill Yancey was on there. I forget all of them now, but it's just the people, if you follow, like this is our era coming through. Certainly George and I came through this earlier era. And these were the people, we read their articles all the time. So this is, you should read it. I think it's 1970, circulation, 71, 70, something like that. Dirk Dorer, if you don't have the reference, I'll get it to Ashita, and we'll get it to all of you. This is must reading. I'm just telling you, this is must reading. If you don't even go to EP, if you just want to be a good solid cardiologist and read ECGs, if you understand this, you'll get it, okay? Classic article. And this shows you how the atrium's activated. It starts at the sinus node, which is at the SVC RA juncture. It's radial spread at a normal heart. You can see it goes caudal to caudal cranial spread down here. It also goes across Bachman's bundle. The last area of the atrium to be activated is left lateral part of the atrium. And you can see down here, total P wave in a normal heart is about 100 milliseconds, right? So, do you have a question? Just, I'm boring you, or you're tired? It's why you probably stayed up and watched the Duke game, right? No, we're okay with that. That's fine. We're okay with that. No, I'm kidding. You do understand this, we poke fun, so don't. We get a lot of pokes, so we poke back a little. So anyway, classic article, this is normal, right? Now, so we'll come back to that in some tracings later. This is, so if we go by our criteria, is this AV node dependent or independent? By that I mean you need the AV node to sustain tachycardia. Independent or dependent? Independent, right. So if you do George's question, which I didn't do, and say, would you give atropine? I mean, would you give adenosine like a lot of dum-dums do? Yeah, you'll have P waves starting about from there to about over to there, and you'll start to sweat it, and you'll get ready to call a code. And the one nice thing is, this is a fellow-friendly drug, adenosine, because by the time you've called the code, the effects are gone. I call it fellow-friendly, and you almost screwed up, and then you find out, oh, geez, I didn't realize they're a heart transplant. Now you're back in trouble. But anyway, you don't give adenosine to some AV node independent. It goes back to George's point with AFib. It doesn't do anything. Okay, that'd be a dumb move. So this is an AV node independent rhythm. If you want to get them out of it, you proc, ibutylide, pick which primary antiarrhythmic drug you like. Don't give verapamil. Yeah, I know it can blow out. Don't go for I can see it happening. There are exceptions to the rule, but don't give verapamil. Give something that affects atrial tissue, okay? Proc, ibutylide, I don't know what people use these days, or shock them out of it if you want. I don't care. This is a very simple flutter concept. Flutter is much more complicated, but in a classic cavo-tricuspid isthmus flutter, it sort of goes around high right atrium, over the crista, back up again. It's three-dimensional. It's not this simple, but that gives you the classic sawtooth pattern. 2-3 and AVF are down P waves. It's a metronome. It's precisely regular. P waves are typically upright in V1. That's classic cavo-tricuspid isthmus flutter. You'll see examples of this. This is what some people call flutter fib because they don't understand there is no such thing as flutter fib, that flutter occurs or fib occurs, and they, with rare exceptions, they never occur together. But parts of the atrium can suddenly regularize a little bit. Al Waldo showed this with some classic stuff he did at Alabama in the 70s. A beautiful series of papers on this. If you have an electrode on a heart that's fibrillating post-op, sometimes you see it become regular and then it becomes irregular. And when it becomes regular for a short period of time, it almost looks regular. Put your calipers on and you'll see it's not perfectly regular. And if it's not perfectly regular, it's not cavo-tricuspid isthmus flutter, or any flutter. Okay, flutter is regular, like a metronome. Then there's classic PSVTs, again, a little bit of a cartoon. AV node reentry is a micro reentry circuit. Classic AV node reentry, you go back to the atrium, the same time you go to the ventricle, leaves you a little R prime. Classic AV reentry requires time to go to the ventricle and come back up. So the P wave sits in the early ST segment. Here's an example of someone in sinus rhythm, V1, and you could see a tiny little R wave during AV node reentry. People always, I don't know what they're looking for, some huge R wave. It's a little tiny P at the end, but it's a wonderful ECG sign. I guarantee you can go home, you can bet on that every day and you're going to be right. AVRT typically has a P wave in the early ST segment. Now, that doesn't rule out AV node reentry. The other thing, if this is really a P wave here, rules out AV reentry. You're never going to see a PR, a RP that short in AV node reentry, AV reentry, sorry. Okay. And then there's this fascination with long RP tachycardias. What is the most common form of long RP tachycardia? So why are you so fascinated by it? You see it every day on a treadmill. You see it every day on a Holter. I don't know. But people are fascinated by it. It's just, right? It's just a measurement. But it does, in the lab for the EP guys, this is always fun because it's harder to work out. You know, it's not, you got to do some maneuvers. George Klein's lab's shown some mistakes on some of this VAV stuff. When you get to the lab, we'll go, I don't know, maybe George can get into that later. But remember, it could be anything. It could be sinus, it could be an atrial tach, it could be AV reentry, it could be AV node reentry. A quick satellite, we had to do, as we do every 2 years, an update on our, life BLS, and I actually wrote a letter. Okay, it's all computerized now. They asked the question, George, how's this? This is the American Heart thing we have to do to get recertified. The question is the following: what is the upper limit of sinus tachycardia? Well, there is none, right? So I have to pick something. So I picked 150 because it was, because they kept talking about 150 is the break point for hemodynamics. I said they're looking for that. And so the answer is 130. So there's a place for comments. And man, you should have seen my comment. I said, I'm a fairly senior EP who's written a textbook in the field, chaired the boards, and been president of HRS. And I'm here to tell you, you don't know what you're talking about. And I went on for a whole paragraph. And I said, yes, you can get a hold of me, because they asked that. And then you can't get out of the damn thing without answering the question, though. So it comes back again, just like your guy, George, where you had to answer it, comes back again. And I know it's 130. So I pick 130 and I put a comment. I said, you're still wrong, but I have to move on, so I gave it to you. But trust me, you don't know what you're talking about. So I'm just telling you, sinus tach could be anything. All right, real quickly, here's a long RP. We can go over the mechanism later, but here's a long RP. You can see it terminates. Could be anything, but actually this one is a clue. And then there's, of course, junctional tachycardia. You can get this thing called isorhythmic dissociation. I always love an old term about this. It's really a cute term. The P wave flirts with the QRS. Flirts with the QRS. It never goes through it. It just flirts with the QRS. And if you think about it, that's how you distinguish this from heart block. Because in true heart block, P waves eventually will just keep going. This is two rhythms that are isorhythmic, P wave flirts with the QRS. It's a very cool term, old ECG term. All right. I don't think, you know what, I can save some time. George did a great job on this. I was going to just show you some mechanism. I'll just show you a couple pieces of physiology. I won't go through the rules. George has already done that. I think you need to know, you'll see this all the time. You'll see somebody start with a right bundle or a left bundle and stop. It's a long, short, which is the classic Ashman phenomenon. This can stop. If it stops after 4 or 5 or 6 beats, it's typically because there's a combination of refractoriness of the action potential. The right bundle, as the rate's faster, actually self-corrects, right? The right bundle gets, with cycle length, his Purkinje system is very, very dependent on cycle length. So as the rate speeds, the APD shortens, and then you get through. That's a lot different than a patient who has this persistent bundle branch block, and suddenly you put a PVC and then everything is normal, okay? That's classic concealed conduction, transeptal concealed conduction. Again, you have all these things there. That would be a block of a bead here, like down the right bundle, goes around the left, comes back, and enters the right bundle. Now, I know we draw it this way, but in timing, actually, this piece of the right bundle is activated way out here. So that it perpetuates itself until you do what's called peeling back refractoriness. So you put in a PVC before you let all this happen, and it comes up here and prevents this from happening. And eventually, then the next beat, it gets down both. So this kind of thing, which was first shown in humans by Hein Wellens, studied in the basic lab by Gordon Moe's group, is transeptal concealed conduction causing the bundle branch block, persistence, okay? Different mechanisms. And I'm just going to end with this one, George, because this is kind of what you're getting at. Everybody is looking for the classic old criteria of AV dissociation, P waves. Not anymore. You know, those are VTs that made it. You know, those are people who made it in with a rate of 130, 100. People going 250 a minute either either die suddenly, okay, or get lucky enough to come in and get cardioverted. And the reason you don't see all these fusion beats and stuff that you want is this. Because to have a fusion beat, remember, the VT going along is continually getting into the AV node, making it refractory. So to have a fusion beat, you have to have a slow enough VT that one of these beats can finally get through, just like that PVC I showed you. But if you're going at a rate of 150 or more, it's really unusual to see a fusion beat. And about 50% of the slower VTs go 1-to-1 retrograde. So you're not going to see a fusion beat there. And the fast ones, you're never going to see a fusion beat. That's the one George showed you. So to spend 4 hours trying to find a fusion beat is futility. So I'll go back to George's point. If it looks like a duck and walks like a duck and they're not pregnant, it's a duck, right? That's an old rule for murmurs, right? So you got to remember that rule. If it walks like a duck and looks like a duck and you're pregnant and you listen and you have a murmur, wait till they give birth and go back and listen to them again. But in this rule, if it looks like VT, it's VT. All right, simple as that. I have some others, but you know, George went over this great. I don't have to do this. You can look at these mechanisms here. George was giving you some weirdos. These are from our book. And I think what I'll do is, since he went over this so nicely, I'm not going to do any more. He covered that in a great manner. And I think are there any questions from yonder? We're good. Any questions from you all before we take a break? Any? Yes. We'll give you a mic. You can ask any of us. It doesn't matter.
Yeah, I just have a question about Dr. Klein's presentation, the last ECG about the infant. Yeah, you said that the treatment of choice is prokinamide.
Well, the drug of choice for a stable VT is what? In anybody, never mind a kid.
You have the option. It depends on what type.
What would you have chosen?
I would have, because I answered adenosine.
Well, what would adenosine do to most VTs? Now, there are adenosine-sensitive VTs.
That's exactly what I saw on the
But if you look at the universe of VTs, the adenosine VTs are going to be 1% or less. I mean, it's something that's in the books, but don't bank on it.
No.
When I teach at different levels, of course, and you try to match what everybody needs to know.
I see.
You guys are merging into the more complicated stuff, and we want you to understand the basics. But I can give this to emerge docs, this lecture. You know what I teach emerge docs? if you don't know what the hell's going on, give some adenosine, record the 12 lead, and then we'll see what happens, buddy, okay? And then they'll say, ooh, sometimes adenosine stops VT. I said, okay, well, if it stops VT, you've won. This is good, right? You're done. And, or if it doesn't, if it does nothing to the cycle length, if it doesn't penetrate, then you can say it's probably the AV node's not part of the circuit. And you can say, well, it's probably VT. The AV node's not part of the circuit. So procainamide is your drug of choice for stable VT. IV amiodarone is a bad choice for stable VT because its active metabolites take a while to get into the system, right? So desethylamiodarone, the other metabolites, they're the ones that prolong refractoriness, and that takes a long time. You know, the emerge docs particularly like to use amiodarone for anything that walks in. Do you think IV amiodarone is a good drug for acute AF, new onset AF? Why not? Why is a lot of them give IV amiodarone, and they say, well, it works. The thing is, when you have a placebo-controlled trial of IV amiodarone in paroxysmal new onset AF, what do you think happens after the curves only differentiate after 12 hours or something, 10, 12 hours. So IV amiodarone is not the drug of choice for stable VT, all right? It might be a choice for ugly VT, and in fact, it probably takes the place of beryllium in the old days we used to use.
Yeah, no, I think George is right. It's thought its immediate effect is anti-sympathetic, and so for these ugly polymorphic ischemic VTs, that's why it probably works. That's a classic board question too, right? We were on the boards together, and that was a question we would put on. What are the ECG effects of IV amiodarone? Right. Just to play with you a little bit. And if you said anything that involved the QRS or the QT, back of the line.
It's actually
sinus node and PR.
That's
it's
right.
Sympathetic, right?
First 7 days, its major effect is AV nodal and sinus node, and its effects on the atrium and ventricle. Actually, Brent Mitchell did the pharmacologic study in both dogs and people. Takes 2 or 3 weeks at regular doses till it has any effects on the ventricular effective refractory period. So that's one of the reasons why, if you really wanted to have an effect on the ventricle, you can give 3 grams and then 2.4 grams for a couple of days, and you have to get 5 or 6 grams.
Yeah, you got a good loading dose. Yeah.
But after 8 or 10 or 12 hours, you're starting to get something. And the other thing about AF, new onset AF, there's a high spontaneous remission rate. Even if you bless it, you're going to get a little bit of
in fact, George, no. In fact, to George's point, I will tell you, you're going to see this if you become, you get yourselves into the next level. You'll get a patient sent to you, and the note will read as follows. Patient in the ER. I love this. Patient came in with RVR. Really? That's a diagnosis, RVR? And then you read further in the note, rates of 110 to 120. It's like, to me, that's like sinus rhythm, for God's sakes. RVR for me is like you're pushing 180 to 200, right? I mean, like I'm going to worry about 110. That's RVR in this. And we gave them IV diltiazem. Classic story, right? And it converted them to sinus rhythm. All the time. I'm going to promise you, all the time. And the patient comes in and tells you, they gave me something that stopped tachycardia. And right away they didn't give him ibutylide, or Proc. And these ER docs, right? They're either going to shock him or give him IV diltiazem. Or maybe amio, right? But they never give him ibutylide or Proc. So it's like, let me look a little further. And they say, oh, well, actually, you stopped on your own. No, doc. They gave me this drug and it stopped. I said, okay, I'll give you that drug. You'll never have it again, See how that works out for you. But anyway, George is right. You could have given him a sugar pill and it would have stopped in 3 to 5 hours. That's why this whole PIP, another topic, is something we could discuss if you want. I'll bet you if you poll the 3 of us, how many patients we have on pill in the pocket, you'll find probably less than 5 from each of us, as a guess. I've got 2. 2 doctors who won't take anything until, they just force me into it. 2 out of, I can't even tell you how many thousands of AFib patients I've treated. 2. So it looks good. Let's do PIP. But anyway, we digress, as always. Other questions? Yes?
Just the same case, just out of curiosity, do you happen to know the mechanism of the VT in the infant case? And also like
Sorry, what was your first question?
About the same case, the infant case with the VT?
Yeah.
Do you happen to know what the mechanism was for the VT and also the VT
No.
localization? Okay.
Sorry, I don't know, but it looked like an outflow VT from morphology, all right? So it looked like an idiopathic outflow VT that I don't know how common that is in infants, but the morphology was outflow VT, so I would bet that it was an idiopathic RV outflow VT.
Yeah, do you mean site or do you mean mechanism?
I guess both because.
Well, it's going to be
my other
automatic, right?
question- Yeah, because my
From
other
the
question.
tracing you show, it's almost surely automatic.
Well, it's RVO-TVT is by and large abnormal automaticity.
Right.
Focal abnormal automaticity, RVO-TVT, idiopathic. Yeah.
Because the other question I had was that the localization of the VT or PVC in infants who are tiny, is it going to be the same with like adult anatomic locations?
Oh, that's interesting. Yeah, I don't know. Actually, I don't know if the rules apply exactly the same because the hearts are small. You know, the V's are they? I don't know enough about that.
I don't think the rules are just different because there's right heart dominance and it takes a while for the right heart dominance to go away. So you'd probably almost need a normal set for 3 months, 1 year, 2 years, so on and so forth. That's why we chose adults because what you see is what you get. It's you have a fixed dose. You don't worry about milligrams per kilogram, this, that. You have to actually sit down and calculate something. That's tedious. Sorry about that.
Ask questions. Listen, we've packed in so many more slides than you're ever going to be able to go over. We did that on purpose, not knowing how. We have a whole weekend. But the questions are critical, important. So we want to take your questions. Don't feel like there's no such thing, honestly, and I know you've heard this before, but we really feel this way. There's no dumb question. Everybody learns at a different level. Somebody knows this, somebody else knows that. So we're here to try to help you. So if you have a question, don't feel embarrassed to ask, and we're around during the break too, so you can, if you have things you want to ask us. By the way, also, everybody has their own level of comfort with masks. And I want to tell you, don't worry about if you want to wear a mask. I'm fine up here teaching, but I'm a little older guy, and I can tell you, when I walked in here, I had a mask on. I just took it off when I got in the room, and no one's going to say, how come you're wearing a mask? At least none of us are. Dr. Ellenbogen's got a mask sitting right up here. So that's up to you all. We don't care if you wear them or not, but don't feel like, oh my God, I'm wearing a mask, so I must be some wuss from Michigan. Where's my Michigan guy? Michigan. I am sorry, but you need to know, there's not a school in the country I would want to lose more than Michigan. It's right? You know that. Yeah, and I get the same with Duke, so don't worry about it. All right, Sheeta, we give them 10 minutes? 10-minute break?
Yep, 10 minutes.
All right. Nice job, George.
They will never tarnish your memory.
these words of mine. I always thought that I'd be fine with you. But ever since we crossed that line, got your green eyes in the back of my mind, it's true. But I can't be just friends. You're messing with my head. And I know what I said, but these feelings, they keep running the red. I got your heart on my mind, and you said that I could come by anytime. But I can't fall in love tonight. I can't fall in love tonight. I got your face on my mind, and it was fun running around for a while. But I can't fall in love tonight. I can't fall in love tonight. Two steps forward, one step back. It won't be long for my heart to attack. You're coming since for second place to the way it feels when you kiss my face. Yeah. But I can't be just friends. You're messing with my head. And I know what I said, but these feelings, they keep running the red. I got your heart on my mind, and you said that I could come by anytime. But I can't fall in love tonight. I can't fall in love tonight. I got your face on my mind, and it was fun running around for a while. But I can't fall in love tonight. I can't fall in love tonight. Oh, I can't fall in love tonight. Can't fall in love. No.
I saw a cigarette contend. It was the smell of death that kept strolling in. Maybe that handed back of yours that held me back from keeping score. There goes that moon, boys, like a jungle with all sleeves growing. Split down that long back. You would have thought that if you got to know one, true blue with the fist up, your little kiss up, wish things were heavy. That's fine in the end, though. Where all our friends go, we can live if you're ready. I bet you take me for a fool. Nothing like booze, the cool sensation of Balkan juice. Somewhere I landed in the sheets. Though the tongue tastes good, my grandar's falling from the cheeks. There goes that moon, boys, looking jumpy with all sleeves growing. Split down that long back, you would have thought that if you got to know one. True blue with the fist up, your little kiss up, wish things were heavy. That's fine in the end, though, where our friends go, we can live if you're ready. I was wrong. You were a friendly kid. I was wrong. You were a friendly kid. Fill the rafters, right field dances, baseball diamonds, take all chances out.
There's something fiction about the way that reality's going. Seems like the chakras playing hopscotch, anxiety growing. Some causal framework of the sun.
No. All right, let's get started, everyone. All right, now to the fun part of the program. Can we get everybody seated? Now what we're going to do is move into the unknowns. And I know everyone loves this. We're going to want to take volunteers up at the board. I know. We got all these. Good. We got Michigan. Come on up here. I promise I will never make fun of Michigan again during the rest of this hour.
Very long time.
That's a long time for me in Michigan. Here you go. So I'm just going to let you do your thing. This is in your books, and it's on the thing. So a microphone for him. Oh, okay. That's very clever. Look at that. You get your own little mic. Classic thing in ECG work as well as EP work. It's like carpentry, right? Measure twice, cut once. Measure twice, cut once.
Okay. So I see a sinus rhythm. There's more P waves than there are QRSs. There's twice as many P waves as there are QRSs. The PR intervals for the P waves immediately for the QRSs are fixed and short.
Normal, right?
And normal, yeah. And then the PP intervals between the conducted P waves, I think this P wave is conducted and the next P wave are fixed, and the P waves in between those are a little bit longer. So I think this is a 2-to-1 AV block and I think the question is like, where's the level of block? And I'm guessing because the the PR interval of the conducted beats are short, that it's probably at the level of the hiss, and that this is ventriculophasic sinus arrhythmia.
Very damn good. How do you know it's not PACs by Gemini?
It conceivably could be.
Could it conceivably could be?
Let me see.
You're doing a great job, by the way. I'm doing what's called peel the onion.
I guess if it was a PA, it's just the pattern happens so regularly, so often.
Well, that's what happens so regularly, so often. Isn't that the criteria for atrial bigeminy? Otherwise, it's like atrial PACs or something, right?
Yeah, I mean, I don't know why they're. I guess.
Shape of the P wave. Okay, you got help from the audience.
They look identical.
Yeah. So have you ever heard of sinus node reentry?
Yes.
So what do you think the P wave would look like if it came from the same site?
Exactly the same.
So that would no help your audience member there. But it was a nice try. We appreciate your helping. So a lot of it, as George said, you're doing great, by the way. Mm-hmm. You really have got it. I'm gonna dig down because I'm supposed to, right? I'm gonna bring out a few points just to add to the flavor. You're doing a great job. So could it be an atrial bigeminy? You can't totally rule it out. It would be highly unlikely. And then you'd have to answer another thing for me. And that is, what is the PP interval here? Like 800 milliseconds,
yeah.
Right? So now you'd have to tell me why a PAC 800 milliseconds out would block. I mean, if that's the case, you should have complete heart block, right? Because it's pretty much, you'd have nothing conducting, right? So while it could be, so this is what George was getting at. You don't know, it's an ECG, and you have to take all your information and make your best call. And you did make your best call. I agree with you 100%. But there are other things that would make the other diagnosis less likely, right? You'd have to explain why such a late PAC wouldn't conduct.
Block, yeah.
So that was great. Now, you mentioned ventriculophasic. Why don't you teach me a little bit about that? I think you're right. I'd like to learn a little bit more about it.
So I think the phenomenon is that when you have QRS in between the P waves in a situation like this, that interval is shorter than the interval where you don't have QRS in between. And the mechanism, I think, has to do, it's like the hemodynamic reflex,
with involving the carotid baroreceptors, where there's like an acceleration of the sinus rate at some point when they don't see a pulse, and that's why this interval is shorter, and then that's why this interval is longer. That's my understanding of the mechanism.
Well, you did a good job, except you have the concept right, but you've got it kind of backwards.
Okay.
In other words, there's not an acceleration of
Deceleration,
the yeah.
Yeah.
So
Sure.
So the question is, these two are longer interval, right? So these two are longer interval, and so that would mean what you're saying is the hemodynamic. This will have, as you know, in slow heart rates for some people, you can have hypertension, right? So you have a very big pulse pressure here, gives you a carotid reflex.
To slow down your rate.
Too early to hit this one.
Yeah.
Okay? So it hits the next one. The tower duration of this reflex is very short, like 500-600 milliseconds. So it's gone. I mean, so it's there quickly, but then dissipates quickly if you read any of the basic studies on it. So you're right, but this would be the normal sinus rhythm rate. This baroreflex is so high that it will affect the next sinus beat coming out. But that dissipates quickly, so the next P wave is now on its normal course. You had it exactly right, but just kind of the other way around.
Understood.
So that's great. So tell me again why you think it's in the HIF.
So
I agree with you, by the way. I just want you to say it one more time.
Two reasons. So it's a narrow QRS.
Okay.
And then the PR interval is short.
Well, you keep saying short.
Normal is what I mean to say.
Yeah.
Yeah.
I think you're right. So that's great. You're spot on. What would you like to do? This patient comes in totally. I was given this sort of thing. It was a rhythm strip. When I was seeing patients in the office, somebody said, they come up, Dr. P, this person's asymptomatic. What do you want to do? So what would you like to do now? You're the EP attending. You can do anything you want. That's not true of all EP attendings, but I'm going to let you do anything you want.
So, I'd want to know if the patient's having symptoms.
No.
And I think
asymptomatic.
There's things that you could do to just prove this to us, I guess. So we could have this person walk, and the block should worsen in infranodal disease.
Okay.
In that situation.
Okay.
You can also do a study, see exactly how long the HV interval is.
Okay.
And that might influence you one way or the other.
Well, let's come back to that. So how long the HV interval, since you raised that question. You're doing great, by the way.
Yeah.
But you have to understand, it's my job to dig a little bit.
That's why I'm here.
Okay. So let's go with those intervals, because you made a great call to begin with. So we're going to say this PR interval is about, 170 milliseconds. So you'll give me, we'll take 30 milliseconds to get to the AV node. We'll say maybe 80 milliseconds to get through, maybe 90, something like that. So is the HV interval, do you think, likely to be long?
This is 170, and you basically said to get to the AV node was about 100
let's say it takes 30 to 40 to get there, like I showed you.
Yeah.
And we'll say it takes 80, I'll give you some small numbers, 80 milliseconds to get through. So that's 120. Now you got 40, 50 milliseconds left. So is the HV going to be abnormal?
In that situation, no.
So you're correct to say you think it's His-Purkinje disease.
Yeah.
But if you do an EP study, the chances of the HV being long are exceedingly low.
Okay.
And that's the difference about Hisian disease and AV node disease. You will not see 2-to-1 block with a normal AH interval, but you'll always see 2-to-1 block with a normal HV interval. Happens all the time in the lab. That's stuff we learned in the early days of EP testing in the 70s, okay? So unlikely, but I agree with what you're saying, probably His-Purkinje system. So since you asked for it, I'll give it to you. So here's a treadmill. So what's happening now? Does this help your diagnosis?
Yeah, the block is worsened.
Right.
Here, I think.
Yeah, no, you're right. Absolutely right. Okay. So the block is worsened. Now, I would not have done this, quite frankly. I mean, because sometimes the patient can pass out on a treadmill.
Yeah.
I mean, if it really gets bad. But this was done by one of my partners. I don't know why he did it, because he probably...
Needed a slide.
No, this is the thing I did. I needed a slide. I told the patient, I told the patient that, are you an EP or a third year?
Third year.
Well, do you want to take this? I mean, I don't know how much EP you've had. You're at the Michigan group?
Yeah.
So you got great guys there.
Yeah.
So
Sure. So
can everybody see the slide? You see what he's going to be doing? Okay. I'll sit for a second and use the pointer, but you go ahead. You're doing great. I'll just point out.
Let me
what
decide
you-
where the.
So
This
why
is
don't
the
we-
hiss here, right?
Yes.
Okay.
That's a hiss.
All right. So here, is there a hiss here? I don't really see a hiss.
Well,
in this.
what you have to understand is oftentimes these cases, you don't get just the beautiful straight things.
Yeah.
You're sometimes lucky you get a damn hiss to begin with. I mean, I've had plenty of cases where I've searched 20 minutes and can't see the split hiss.
Right. It's diseased.
Yeah,
So is
so
this-
you can't sometimes, but we got lucky here.
Yeah, split hiss here.
Yeah,
Is that
you
what
see
you're
the
saying?
split
Yeah.
hiss? So this is a nice A, a nice hiss, a delay in the hiss, just as this young man has predicted. We have to sign you up. Medtronic, send me his name. Except he'll never come to any Dookie program, so we're going to lose him. Anyway, you can go to Canada. George is neutral, so it's a neutral turf. Anyway, so you see the split between the hiss? We were able to get lucky here and get it. Okay, but there's no block below yet, but you'll see on this slide, when block occurs, where's the block?
So here's the hiss, and there's no V.
Right, and that's the first hiss,
Yeah.
right? So so this is intrahissian block. Critical concept, you got to know it. It's the same danger as infrahissian block. And just to review one last time, you got it all right. You did a fabulous job. The criteria you need to call something probably in the hiss is 2-to-1 block at a rate where you shouldn't really see 2-to-1 block, normal PR interval, and narrow QRS. There's no godforsaken reason that you should be blocking 2-to-1 in the AV node in that situation. It's just really no reason for it. The fact that QRS is normal tells you that the bundles below the hiss are not diseased. Well, remember that little diagram I showed you, a little railroad track going down? Hiss is one of those things, and that goofs up everybody, but not you. You did better than your team. I'm going to call. I'm going to tell him that he needs to hire you. Terrific. Very well
Appreciate
done.
it.
Yeah,
Thank you.
I'll give you a bump.
All right, thank you.
Very well done. Congratulate him. That was terrific. Thank you. All right.
How about the implications for hiss pacing? Do we talk about that now or not? Ken?
I'm turning that over to the Ubermeister Hiss Pacer.
Would you hiss pace that guy or left
Well,
bundle
wait.
pace?
Now he's going to give you some feedback here because he's beyond his pacing. But go ahead, Ken. Tell us what you do.
So,
Get mic one?
yeah,
No.
my mic is on. So I think this is a patient in whom you could pace in the distal hiss because the side of the block is somewhere in the hiss. But distal hiss, you have to worry about thresholds, but we would pace that patient below the hiss in the left bundle.
Maybe we're seeing that more often than is apparent from Eric's nice slides, because maybe that's why his bundle pacing or left bundle pacing works. It works if it works in patients where you don't see that, obviously. Well, that would suggest that you're dealing with intrahissian block in more places than we think we do.
Correct.
By the way, to make sure I keep my Medtronic friends out of trouble, there's not an approved use of any product, left bundle pacing. This is just research that Ken and some others are doing. That's the only thing I'm going to say.
Just reflects my personal, private opinion. That's what I'm expressing here. But yes.
Okay.
This is a beautiful patient who would do absolutely fantastic with conduction system pacing. His electrocardiogram will look great, and we know that most of these probably the lead is right below the tricuspid valve. So these patients do extraordinarily well. They have good pacing thresholds. Their QRS looks beautiful, and the risk of pacemaker-induced cardiomyopathy is extraordinarily low.
Thanks. You can always tell, I mean, we had to go, I don't know if this is true in Canada, George, but they get so crazy with HIPAA stuff now that I can't have any identifiers. So I used to have, you remember all my old slides? I would have like a date of the lab study, or like, it would just say 199 or something. I had to take all those off, make new slides. So to tell you if this person was his bundle pace, I can promise you not. This is the L series. I'm into the S, and there's 100 per series. So this was, I'm sure, 5 or 6 years ago, and I guarantee you we weren't. You may have been doing that, but we weren't. All right, very well done. Let's go on to the next one. Thanks for adding that, George. Okay, who would like to take this one? All right, come on up. You have 2 choices. You can take a pointy one. What do you like? You like the pointy ones. You gave me a pointy one and a dull one. I don't know. All right. Why don't you tell us who you are, where you're from?
Hospital.
Where?
Yale.
Yale. Yale, New Haven. Yeah, well, sorry.
Not Michigan. So.
I'm sorry about that, Gabe. Yeah, that's right. But you had a good season. You got in the tournament, right? Come on.
Right, yeah.
Everything's basketball right now. I'm so sorry. If you don't like basketball, I apologize. But for me, it's all about basketball for 2 more weeks. But Beth doesn't like basketball. She's into hockey. What are you waiting for, Tulane? Seriously? Okay, go ahead. Go ahead.
Sure.
I'm going to sit down and use the pointer as you're pointing things out. So go ahead.
So in terms of the rhythm, we're looking at clear P waves here. It looks like pretty regular sinus-looking P waves.
Why don't you use your, well, did you already use your calipers at the seat? Don't you want to just confirm that maybe?
So pretty so far.
Right, so, yeah, so you've confirmed it, right?
Right.
So they're there and regular, right? Okay, go ahead.
So there is a QRS after every P wave. The PR interval also looks fixed between each P and the subsequent QRS. But then there is an additional QRS without a P wave before it.
Okay.
The morphology, it's right bundle, but it's pretty sharp upstroke. In my mind, it argued for an aberrancy. So conduction with aberrancy, so this could be a double fire from, you have one P wave with.
So I'm going to ask you something. I know what George went through, and I do understand all of his points, but in V1, if I just asked you, is that a classic right bundle? I'm not saying you're wrong in your interpretation, but I would argue for you, I would argue with you and George for that matter, that while I totally agree with where you're going with the intrinsic part, that's not a classic RSR prime. It doesn't mean you're wrong. I'm just saying this shows you the variations that George was trying to point out. Yeah, you want to say?
Just to make a comment, because I spent about 20 minutes on this, so I want you to listen. You look at V4, 5, and 6 for that beat, and tell me whether the initial forces are the same or different than the sinus beat. So go to V5, okay? Go to V5, and you see a normal one and an abnormal one.
Right.
So are the initial forces the same?
It's slower on the.
It's slower, it comes later,
Right.
it comes later into the, it's at least 40 milliseconds down, it's a different direction.
Right.
So that's a PVC, all right? So
The only thing, though, if it was a PVC, why don't we have any I mean, there is no concealed.
you've got
conduction.
2 to 1, you've got a constant bigeminal rhythm, so you can't tell that because you don't see 2 sinus beats in a row.
He's not going.
All right? The second reason why it's a PVC, which is what I try to tell the medical students, is there's no P wave in front of it, buddy. Show me the P wave in front of it.
Oh, yeah, I mean, that's not.
Show me the P wave in front. There is no P wave in front of it.
So could this be, that's what I was saying, could this be a double fire? Where
Well, it could be a double fire, all right? So, but it could be a double fire, but the morphology is ventricular morphology. It's not a classic. So we said before that morphological criteria are probabilistic. So if I had to bet my firstborn on it, maybe I wouldn't. My car, I probably would. My car against Eric's car, I would, all right? I'm sure he's driving a hell of a lot better wheels than I am.
Well, I don't know. What are you driving these days? Maybe you
I got
don't
an
know
Audi
that.
S5.
How much?
Last year's Audi S5.
Okay, I'm driving a better car.
There you go. Well, I'm happy with my car.
Well, my car isn't brand new, but it's a Maserati.
Yeah, well, there you go. So
But it's
I'll
not
bet my
brand
car-
new. It's
my
not
car
last year's
against
model.
Eric's. There you go.
So-
My car against Eric's. So it's highly, I mean, probabilistically, it's ventricular morphology. There's no P wave in front of it.
So this is why I showed it. So let's go back to him. So you jumped on this right away, and I struggled with it. I have to tell you, I struggled with this one when someone brought it to me in the office. I actually came down on your diagnosis, but for a different reason than what George is saying, because I'm going to tell you that's not a classic right bundle, okay? So when I first saw it, I wondered about a bigeminal rhythm, okay? But you actually said something that's critical, but you missed one other thing. I'm actually with your diagnosis, but initially when I saw it, I was leaning to the PVCs. But then two things pushed me. So let's go back, because it is not classic right bundle, okay? And 2-for-1 responses are just not common, and PVCs are. So if you're going to play the odds, you'd have gone with the PVC. That was my quick eyeball. And then I said, oh, wait a minute, Eric. And that's when you have to look at it. So I want you to look carefully at this rhythm strip now and dissect it and tell me. Now, one of the things you said is very, very good. What did you say here? Because this is critical, and I agree with you, right? What did you say here about this sequence?
I would have, if it was a PVC, I would have seen or expected more compensatory pause or concealed conduction.
You would have expected some. So now you'd have to. So now as you start to layer this is what George and I have been talking about in Kent. My initial eyeball was actually what George was. Like, come on, this is a PVC, you know, it's bigeminy. And then I sat down with it and I said, wait, I'm missing something here. Something doesn't smell right. And that was the first thing I saw. And now I'd have to say it's a bigeminy with 0 retrograde concealment into the AV node. And that is exceedingly uncommon. But then there was one other thing I saw as I looked at the whole strip. Take a look at these beats. Just walk through and tell me if they're all the same. That's what I want you to do.
Yeah.
Are they all the same?
No, like...
they differ, right?
There's no more.
They differ. So if it's a PVC, unless there's fusion, they should all look the same. And that was the second clue for me that something that maybe put to you. But you said it really fast. I have to tell you, I had to work at it. So you're a lot smoother at this than I am. Unless you figure these are just, these guys are playing with me. I struggled with this one. But those were the two things I came down on before the patient ever got studied or anything that pushed me to the 2-for-1. The two that you said, which was very good. You missed the other one, but you got this one right away. No concealment. Remember I showed you before? That's why I say you got to learn these basic facts. No concealment hardly ever occurs, right? So why? There's no concealment. So I have to figure out why. And then, why would it be narrow here? Why is it narrow suddenly? The coupling interval, by the way, is the same. So why is it narrow and wide and narrow? Now, the physiology has to start working in your brain, which I'll show you in a moment, okay? We'll go through another slide. So I started with George. I ended with you. But I must say I struggled with it. I had to really make a lot of measurements. Yeah, George.
So I just wanted to point out that I never commit to something where it's your slide. And knowing that you wouldn't just show PVCs, so there's something smelled a rat. But the point is still, that is a PVC morphology.
Mm-hmm. Absolutely.
If you put this on the board,
100%.
The question would likely be thrown out.
Yeah.
Because if you say what is the probability of this? Is it this? The differential diagnosis for any bigeminal rhythm like that is ventricular ectopy, or junctional with Barency, or a twofer. There's nothing else on the differential.
Right.
And of those, the probability of something being a bigeminal PVC are much, 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 much higher than twofers. Right. Except if Eric shows a slide at his course.
Yeah, and again, she came to me as a new patient. You're not done, by the way. But you're doing a good job. No, you're doing a very good job. You're not done yet.
You're
all right.
Not bleeding enough.
Well, we're going to find out why there's changes, right? There's always a physiology reason for changes. Yes?
So quick question. If we were to assume this for PVCs, which we've talked through why it's not, but the fifth QRS comes pretty nearly on top of the T wave.
Wait a second. Fifth QRS, I'm sorry, starting from the left here?
From the left.
Fifth, this beat? Which one you mean? One,
The
two, three?
one.
This one?
The negative one. Yeah.
Okay, go ahead.
So if we were to assume that these were PVCs, would that timing lead to torsades if this were to continue just being a
Shortly
PVC
coupled, like
on the T wave? What are your thoughts on that?
Oh. No, I don't think so. You know, here's the thing. It's one of these things, you know, like Al Waldo loves this expression. You know, it drives me crazy. You know, a dog has 4 legs, but not every 4-legged animal is a dog, right? So Al tells you that all the time. He loves to talk about flutter and stuff. And the point is that you see so many people with long QTs who never have torsade. You have to have a genetic, in my opinion, genetic predisposition to torsade. You see people who come in with QTs of 600 milliseconds never have torsade. And then you'll see others that do. So the vast majority of long QT, I mean, if you think about patients with long QT syndrome, how do they even live a minute of their life? I mean, they have a prolonged QT their entire life, and then suddenly at age, 28, they have a VF arrest because no one knew about it, right? So it's not just a long QT. So I understand what you're saying, and that's a theoretical setup, but no, the vast majority of people who have a PVC there would not have torsade. And I don't think the QT is long either. I'd have to measure it. I don't remember. But anyway, let's dig a little deeper. Let's go to the next slide. So George is right. You never expect me to show you PVC. So I'm sure you, but I will tell you on a test, when I saw that, this is not the first thing I got. The one I got had only that morphology, not the one I showed you. If you had gotten the other one and said a twofer, I'd have killed you. So this one I gave you. All right, so let's kind of go forward and let's look inside the heart. You don't have this, so I'll, do you know EP? You EP? Oh, yeah. Well, go ahead, take it then. Tell me why one's wide and one's narrow. There's always a, listen, I have a statement I teach my fellows, physiology doesn't lie. Physiology doesn't lie. So if you think it's wrong from the physiology, you've made a mistake somewhere, because physiology is hardcore. So if you learn physiology, you get it. So go for it. This is still that same 2-for-1 pattern, okay? Right?
Right.
All right, so this is the pattern you start with. Here's the one I want you to talk about. Talk about this one. You tell me why.
I mean, we
yeah, go
already
ahead.
hypothesized that there is aberration with the second beat because it's closely coupled. Like there is more refractoriness in the right bundle. When it comes down the slow pathway here, the right bundle is still refractory, so the second one was different morphologies, was wider. What happened here is, so here we see a change of morphology where it's actually narrow. And the question is?
Well, you made all those observations. You have to make a measurement. So the question is, why are, the mechanism is 2-for-1. That's, okay? So I wanted to prove the point. So this one is the 2-for-1. Go down here, go down the slow, you get this.
Right.
So the mechanism's correct. That's not what I'm asking you now. I'm asking you why the QRSs, second QRSs are changing morphology. Physiology. His-Purkinje refraction is physiology. Okay. Measuring. So would you say the coupling interval is close?
Yeah, they're pretty close.
Okay, so that's not your reason.
Right.
So what is the reason then? Which interval haven't you measured?
Let's see this one. I think it's also the same.
Okay. Let me see if I can help you a little bit. So the question is, why don't you start here? The question is, this is wide and this is narrow. So remember I said physiologic principle of His-Purkinje we talked about earlier? What did I say? Rate related? And quick rate related. We don't go into the fact that the ventricle muscle can take multiple beats to change its refractoriness. His-Purkinje could be 1 beat. Changes with 1 beat, okay? So, which you're doing very well.
HRA,
well, you have a way to measure something else before this beat here. So let's take what comes before this beat and this beat. What measurement do you want to figure out why that one is this bizarre looking right bundle? What do you want to measure prior to that?
The PP interval.
PP interval? What do you care about the PP interval? That's probably regular.
So this, I mean, this one came in earlier.
It's 2 for 1, so PP interval is meaningless.
Right.
How about dig down a little deeper? What does the right bundle see? The PP interval or something else?
I mean, H is H.
Well, do we have H's on here? What do you think these little buggers are?
Yeah, so those I measure. I mean,
So you want to make a measure of the H's? Give it a shot. You know, just give it a try. See if it works.
so those H.
Forget that one.
Yeah.
This is one that's called here. Put your calipers on. No. Come with me.
HH.
This one and this one. Now, move it along. Oh my goodness gracious. Okay, no. This and this, right?
Right. So it came in earlier.
So if the HH shortens, what will it do to the refractory period of the next complex coming down? Make it longer or shorter? If the heart rate speeds up,
Shorter. Yeah.
shorter, and that's the mechanism of why it's changing. So it's a 2 for 1 with a PVC with a QRS that I thought was a PVC. So I'm just going to tell you, I was with George. But again, I didn't have this tracing. I had one that just showed the wide beats, because it depends on how much HH is doing. So the first one I got was just a rhythm strip, and everyone looked wide, and I said, patient has bigeminy, And then she was a patient sent to me because of tachycardia. So then I started digging for more records, okay? And I said, well, something's got to be funny. And then I finally found this in her chart, okay? When I went and actually looked at one of her tracings, and I don't want to go through all this, but the point is she's having runs of SVT. And then I said, oh, wait. Then I went back and I said, oh my God, it's a 2 for 1 with changing. And then I figured we have to get her in the lab to figure it all out. And we did, and she had, with high-dose ISO, she actually had a run of AV node reentry. But anyway, we got rid of the slow pathway like you're supposed to, and everything's fine. But the cool thing about it is the changing in the QRS. And you got to know a couple rules to figure that one out. But you did very well. I mean, like I said, you did very nice. George, anybody
So
questions?
there are a couple of really, on
Wanna
top
go-
of all that, there are a couple of really amazing
Want to go back
stuff.
to
Yeah,
which
go
slide
back
again?
so there's a name, first of all, a lot of these patients are sent to electrophysiologists for AFib ablations, because if you look at their arrhythmia, they'll have these groups of fast heart beating, okay? And the name of this arrhythmia is AV non-reentrant tachycardia. It actually has a specific name that some people use to refer to this, AV non-reentrant tachycardia. Again, sometimes these patients are actually referred for catheter ablation of AFib. So it is, you find this and you've saved a patient a pulmonary vein isolation. This looks like AFib, often on Holter monitors. People can have just this. And if they don't have good retrograde conduction, you'll never see the SVT.
Right.
And it's the same procedure. You ablate their slow pathway. They feel tremendously better because they really are bothered by this. But I think the general thing is, the physiology is that the refractory period, when you want to look at a refractory period, you always measure the tissue proximal to that. So if you're talking about the refractory period of the AV node, then you want to look at the input into the AV node, which is the septal A to the next septal A. If you're talking about what's going on in the His-Purkinje system, then it's the H1, H2. So the refractory period always gets shorter as the rate goes faster in every tissue, except for AV nodal tissue, right? Because that uses calcium current, and calcium current, as opposed to sodium current, shows different kinetics, and that's why when you increase the cycle length pace more rapidly, the AV nodal conduction or AV nodal refractoriness is prolonged. But this is like a course in EP, the whole thing.
The other interesting thing about that is that...
Great job.
Thank you.
He did a great job. Yeah, great, George.
No,
That's a tough tracing.
these people often don't have AV node reentry.
Yeah,
They don't have retrograde conduction.
Until I found that one.
Yeah.
tracing.
The reason they don't have AV node reentry is because there's no retrograde conduction. You see a 2 for 1, and if you got a 2 for 1, you're giving it a chance to turn around, and it's not turning around.
Yeah, George, you published a nice thing on this. I remember your paper.
Well, thank you.
a while ago. No, I thought it was really well done. I enjoyed it. But in your case, I don't think they had any retrograde, right? That case you
Well, no retrograde, but isoprel can bring out retrograde. You see,
That's what happened
at
here.
baseline, they had no retrograde. So if you did a baseline ventricular
EKG
pacing,
is-
you'd have no retrograde conduction.
EKG is so
right?
good because
It's the only,
they gotta move
so
that
the
rhythm
fact that they
forward.
have both AV node reentry and non-reentrant is a reflection of the fact that they have no retrograde conduction at baseline, but isoprel juices up the retrograde fast pathway so that now they can have both AV node reentry.
Well done. We could do one quick one. Anybody want to do this one? This is fairly quick. And then I'm going to turn the, who's next? Kenny or George?
Next.
So let's get one in. Like I said, we put in many more tracings we'll ever get to. We never know how it's going to flow. Our view of education is we could spend 30 minutes on one slide. We don't care as long as you learn. We're not just trying to get through them all. We'd rather you learn something. But I abhor a vacuum, so I always put in way more tracings than I ever use. This happens every year. But so if we get to the end and there are tracings that you're not sure about and you want to ask me questions, I'll be happy to answer. For mine, I'm not about to answer their questions. Anybody want to take a shot? Straightforward? Thank you. I'll help you, I promise. What year are you, third year?
I'm a third-year cardiology fellow at Montefiore.
Okay, well, oh no, I'll give you this, but you got to get your own mic. I'm sorry. There you go. This is totally not right because everybody's touching this thing. I'm feeling we're probably breaking every rule, Noah. So you're at Montefiore. Yes. My brother's there.
Oh.
You know Prostowski there? He's the head of pathology.
I don't think I met
You never will see him because he's sick. He thinks seeing a patient is the last thing in his life he ever wanted to do. So Michael is in some lab somewhere with his MD, PhD, but he's at Montefiore. But you see Luigi.
Yes, he's my mentor.
Luigi's your mentor?
Yep.
Sit down. No, I'm kidding. When you see Luigi, you tell him, Eric said, how's the ring doing? How's the ring doing? And he'll laugh. He'll know what that is. I'll tell you
Can't
later.
wait to ask.
All right. It's yours. Go ahead.
Well, I'm hoping it's straightforward. I think it's giving a little.
Yeah, is there feedback there? Guys can maybe turn. They'll get it. Go ahead. You go ahead.
So starting with the rhythm, I'm trying to find some P waves, and it's really challenging, but I think if I look in the lead
Try two.
one,
Oh, okay.
there's a little bit of additional signal at the end of the T wave
Okay.
that doesn't fit completely the smooth T wave
How about-
contour.
You want to
Maybe
try?
a little bit here.
Can I direct
V2
you to maybe
as well.
2 or 3? I think it might be a little easier for you.
Yeah, maybe at the end of the T wave
Okay.
in the lead 2 and lead 3. Yeah, this looks a little biphasic, which is also not completely normal.
Okay.
So, the rate is about 100, so it looks, but it's negative. Then if it is a P wave, it's negative in lead 2, 3, and AVF, so it's not sinus. PR is quite long. It's close to 400 milliseconds if it is such, unless it is a retrograde P wave, which is kind of late as well.
Well, by definition, when you say retrograde, so let's be careful. Are you meaning retrograde V to A, or do you mean a negative P wave in 2, 3, and F? So, and the reason I bring that up, remember we talked about activation normally and abnormally. I guess I would put it a different way. Don't think yet of mechanism. Think of where do you think, is this P wave going from the base of the atrium to the top, or is it going from the caudal to cranial?
Well, based on the morphology, it looks like it's activating the atrium base to
Okay,
base
good.
to top.
So it's going from the base up. You now can play with the mechanism, but so when people say retrograde, they start to, in their heads thinking VAs and stuff. I just want you to know how the atrium's activated, because it could just be an atrial attack, right, coming from that area. You don't know yet. There is a hardcore ECG criterion that I doubt if you know, you had already said it, unless you're just sandbagging me. And then I'll place a call to Luigi as soon as we're done and tell him that, why did you bring your trainee here and sandbag me? You guys know Luigi DiBiase? He's like a character's character. He is definitely a fun guy. You're lucky to be training with him. He is really a fun guy.
He's great.
A little crazy, but fine. Go ahead.
He trained with Montanaro. That explains it all.
He did?
Yeah, you remember Montanaro?
Oh, yeah, do I remember Montanaro? He claims you trained him after 2 weeks.
You know, when he was at our hospital, he spent actually 3 or 4 weeks. We never saw him. But every nurse in the hospital knew him.
Go ahead. I'm not going there. Go ahead. So here's what I want you to do now. We're going to make you an uber expert. You right? You're doing great. You're really doing great. This is really a sophisticated crowd. I can tell you 2 years ago when we ran this pre-COVID, people fumbled over some of the same slides. You guys are doing great. So now we're going to hone in now, right? We're going to make you even more uber. So you've already said it's base to apex. Now I want you to look at the width of that. The width of that. I'm sure this is
narrow.
Pretty narrow, right?
To the septum.
Okay, so you're almost there, right? So it's pretty close to the septum. Why did you say it's pretty close to the septum? Just because it's narrow?
It's closer to the. Oh, so it activates both left and right.
Right.
Atrium,
What do you
almost
call
close to
that?
the
So
septum.
something that activates both. Well, it's a term. You know, you ever hear the term cancellation of electromotive forces?
Kind of.
Now you know it. Okay. So in other words, the sinus starts here, and we showed from the Dura paper, it takes 80, 90, 100 milliseconds to activate the heart. You start from the left side, you come to the right, it's that. The only time you're going to see a really skinny P wave is when you're in an area where you cancellate forces, and it's always septum. But there's only a few areas in the septum that are truly the septum. For example, is the coronary sinus septum?
It's close.
Close doesn't count. Is the coronary sinus septum? If I were to take that heart in the OR, like we used to do when we did surgery on WPW, and I went, and that surgeon pulled up that back of that heart, and they had a probe going through the CS. Do you think it would just hit smack into the left atrium, or it would travel through some fat and then get to the left atrium? Our mentor, John Gallagher, all of our mentors, used to say, think of a pyramid falling on its side, and you look at the base of the pyramid. This is how he taught us. And the base of the pyramid looks like this. And here's the coronary sinus in the right atrium. Fat in here. You can put a probe in the OR, go right through, and then the left atrium. So the coronary sinus is right atrium. And P waves from the coronary sinus are never skinny, narrow P waves. So it's the anterior septum. Okay, so now you're almost home. Anterior septum. Going by George, we give you a differential. I'll give you the differential. Could be an atrial tachycardia with a long PR interval. It could be AV RT coming up the septum with a long RP, or it could be AV node reentry with something else with it.
Well,
So make one more measurement. How does this sit between these two? Kind of make this measurement here. I have to be careful. This is a killer here, Matt. One of us, either Ken or I, are going to die from this screen here. It's like every time you move back a step, you go, whoop. So what'd you think? Here. There, it's okay. Here to here. And then, real careful, then move it the other way. Okay, so here to here, and then move that over. No, move it over to here. Okay. No, it's hard with these calipers. So kind of get it like this. I mean, it's pretty close, right? It's almost between the two. Pretty close. You just have to know this one, okay? This is just an ECG sign you got to know. If you want to make life hard, you can. Sir William Osler always said, unify your diagnosis. You know who Sir William Osler is?
Yep.
Now, George knows because he's from Canada. But he did all of his important work at Johns Hopkins. No response? Okay. So I was waiting for him to say, yeah, typical. So if you want to make an atrial tach, you have to make an atrial tach and slow pathway conduction. Because there's no reason at this rate to have such a long PR.
Right.
So you have to give them 2 diagnoses. Who wants to do that? If you want to make it AV reentry, then you have to say you have a concealed accessory pathway coming up, you know, in the septum, anterior septum. I mean, you got to make life hard. This is a classic ECG finding that you just simply need to know. And it's AV node reentry with 2-to-1 block. Oh, I'm sorry, should I not show that?
Just, Matt, could you show me my slide set for 1 second? Show from my computer. I just want to make a point from Eric's slide that's easier to make. You on my computer now?
Yeah, I think so, George.
Yeah.
It looks like you got. Looks like you're here.
All right. So these are my 3-prong calipers. Okay. Which makes it a little easier because I put 1 prong here, 1 prong there, and I check. I call that checking the middle. Whenever I see a P wave hanging somewhere in the middle, I put my 3-prong calipers up and check the middle and see what's there.
Dr. Klein, can you turn your mic on?
Oh, sorry. There. Usually I'm so damn loud, people are telling me to tone it down, so this is very refreshing. Thank you. So I check the middle, and when I see that there's something right at the beginning of that QRS, so that if I had this, and Eric might have a sample of this when he's in sinus rhythm, and you compared it to the sinus rhythm, that little onset would disappear, all right? So this is just a matter of using calipers and tools. You saw how difficult it was for her to caliper that the way with the classical technique that we all grew up with. But if you see 2 P waves right in the middle, you ask yourself, well, is there a third one? Now, because it's a very, ECG readers at our hospital will often screw up and miss 2-to-1 block or something because they don't see this. So that's far more common to get an atrial tachycardia or something with 2-to-1 block and blow that one than to see atypical AV node reentry with 2-to-1 conduction, which is not that common as a sustained arrhythmia. All right, thanks, Master. Flip him back his slide.
All right, so that's funny. I'm sorry, we were just talking about my brother. My brother, I won't even tell you the story because it's an embarrassment to the Prostowski family. Prostowski's parents, mom and dad, were both doctors. My father actually trained with Helen Tausig, you know, Playback Tausig shunt. My dad trained with Helen. And my mother was one of the first child psychiatrists, frankly, in Northeast. She trained years and years ago. And they have 5 boys, 4 of whom went into medicine. One decided to become a PhD. So we have all these people. We believe in in taking care of patients, the 4 of us. And my brother Michael said, I don't want to do it with patients. What can I go into? So I gave him a book called The House of God. Did you ever read The House of God? I said, you have 3 choices, Michael. You can become a pathologist, psychiatrist, or radiologist. He picked pathology, and he never had to see a patient the rest of his life. Of course, he got his PhD at Rockefeller and is world-renowned, so nobody's hitting on my brother Michael. But God forbid you would ever see him. It won't happen. So anyway, this is classic. Hein Wellens, I give the most credit to. I think he's the first one. And certainly, I remember being a course of his when I was a youngster in the field, and he pointed this out. I don't know if he was the first one. But it's AV node reentry. And what we've done is you can see here a PAC starts tachycardia. Where's my long short? Long short does what to his Purkinje?
Prolongs refractory period.
Prolongs refractory period. Long short, a la Ashman and all the rest of the field that talked about this. So you get a long short, and then you wind up having 2-to-1 block below the AV node. That's how this usually starts. And you can see AHV, here's your His, going back to the A, doesn't go to the V. So it puts that P wave smack in the middle. So the classic finding is an anareceptal P wave morphology, which means narrow, a little skinny, 40 to 60 milliseconds, pretty much equidistant, and maybe a little off, okay, but not much, and a narrow QRS. And that's a classic board question. And we would expect you to say, we wouldn't say it is, we would ask the question, what is this most likely? Because you can't be positive. We'd say, what is most likely? And we'd expect, all 3 of us wrote boards, we'd expect you to say, AV node reentry with 2-to-1 block below the His. All right?
So the late, great Mark Josephson always said, beware of the P wave right smack dab in the middle of diastole.
And I've seen many an electrophysiologist miss that, particularly in patients who have had ablation. is once you've had ablation, your P waves are all messed up. They're
Really?
low voltage, and so cherchez le P, right?
Cherchez le P. Yeah, but did they miss it because they just made the wrong diagnosis to begin with?
No, they just read too quickly and didn't look in the middle.
Oh, that's a problem.
Yeah.
All right, so any questions before I turn the calipers over to my buddy Ken? You can see how many tracings they're in there. We're never going to get through them. Like I said, I don't care. We just want to teach, and we want you to learn and have fun. So any questions before we move to Dr. Ellenbogen taking over? I don't think there's no break, right? The sheet will go straight through. Ken, you take over, kiddo. So Matt, could you please bring up Ken's series? I'll move over here. Yeah, it's yours.
So I'm going to get started, but hope everyone really enjoys this weekend, because it is really spectacular to be here and to be surrounded by these two guys. It's really an amazing opportunity, and there are lots of courses, but there's nothing like this. This is really about the physiology of the EKG, and it's sort of the bread and butter, even today, of what we do as cardiologists, and the bread and butter of what we do as electrophysiologists. So much of it depends upon the EKG. I was told to use as few didactic slides as possible, but this was about working through problems. But I found this on the Twitter sphere. It's actually very good advice. I won't read it, but it's good advice for the course. When you come up here, see failure as the beginning. Never stop learning. Assume nothing. Question everything. Teach others what you know. Analyze objectively. Practice humility. Respect constructive criticism. Take initiative. Give credit where it's due. And love what you do. So that'll be what we'll heed to today. I think I have just two slides that build on what George Klein talked about, why complex tachycardia. I'm going to show lots of slides of why complex tachycardia, and some of that will be pacing as well. Just remember that VT is the majority of cases of why complex tachycardia. That's just the way it is. And a history of prior MI, heart failure, recent angina, has a very high positive predictive value of the Y complex tachycardia being VT. So that's just sort of good to know. Here are some myths. Y complex tachycardia that is irregular is SVT with aberrancy. That's a myth. We'll show you some examples of that. Y complex tachycardia that is slow is SVT with aberrancy. Another myth. Y complex tachycardia that is hemodynamically stable is SVT with aberrancy. Never make that assumption. Y complex tachycardia with a one-to-one relationship between the P wave and the QRS is SVT with aberrancy. You've already seen George's version of this slide. It included a picture of the physiology, but just remember, these are all the things you need to think about when you look at a Y complex tachycardia. VT, as I said, is the most common. SVT with aberrancy related to tachycardia. We'll probably touch upon this a little bit more, phase 3 block. And in patients who already have pre-existing bundle branch block. Pre-excited tachycardia, that's tachycardia conducting over an accessory pathway. The accessory pathway can be a component of the tachycardia in that you can conduct over an accessory pathway and retrograde over the AV node, or you can conduct over an accessory pathway and retrograde over another accessory pathway. Well, that's certainly less common. And the accessory pathway can be an innocent bystander, just like the AV node is an innocent bystander during atrial fibrillation conducting over an accessory pathway. But you can have atrial tachycardia or AV node reentry that conducts over an accessory pathway. Ventricular pacing, and you'll probably see a couple of examples of that. Sometimes rapid ventricular pacing, what's that? Electrolyte abnormalities and drug effects can cause Y complex tachycardia. And the take-home message you should know is that all these great rules we taught you about differentiating SVT from VT fall apart when somebody has significant electrolyte abnormalities, or they're drug toxic. So everything we said goes out. All that physiology about QRS onset and patterns goes out. And of course, artifact can give you something that looks wide and ugly. So the EKG should not only tell you how to distinguish VT from other tachycardias with a broad QRS complex, but also one of the things you'll learn, particularly as an electrophysiologist, is you'll have some idea in some cases about the etiology or mechanism. And sometimes, and I'll show you a couple of examples, of where it is coming from. Okay, so who wants to do the first one? Anyone? Volunteers. Okay, well, somebody who hasn't done any one, come on up. You want to do this one? Come on.
Piece of cake for you now, man.
Sure, take this out.
You can, sure, please.
Yeah,
It's,
so
take that, and I think it doesn't have as much. Yeah.
Can you tell us your name and where you're from?
So I'm Sharat Viparthi. I'm one of the first-year AP fellows. I work at Rush.
At Rush. Okay, thanks.
So at first glance, we have a broad complex tachycardia, which looks largely regular. Although if you carefully look, there are periods where it's slightly irregular. But there are certain leads where I thought I imagined some P waves. And if I were to take a calipers,
here you go.
So this does appear like a P wave, and I'm trying to look for something similar. So maybe this one, but that is no.
Doesn't march out, does it?
No. So I would say either I can't see clear P waves, or like there could be some dissociation. And in terms of precordial RS transition, if I have to look at it, like we have no concordance in terms of either negative or positive concordance. We have a like transition and V3, and
Can I ask you a question?
Sure.
Does that look like a right bundle branch block?
It does look like a light bundle branch block.
V4, 5, and 6.
Um,
Does that look any? Are the initial forces the same as they would be? Are they fast?
I mean, it's not a classic right bundle branch block, if that is what you're asking.
Yeah, I am asking you, and it's not a classical. It's totally atypical for right bundle branch block. So that's a VT morphology.
So it's VT. I'm leaning towards.
No, we said too that morphology is always probabilistic.
Right.
So you're better off to say that's a VT morphology. So my first diagnostic guess might be VT.
Right.
Now you went to the P waves right away. That's good, but that's the hardest thing in this whole thing. So why not go to the easy thing? He's given you a nice, clean 12 lead. You have all the morphology criteria.
You're absolutely right.
So by morphology is VT. Now it may not be, as we saw in Eric's last case, but probabilistically you'd have to put that first. And when you say that, then now you can look for the lower hanging fruit, at least the higher fruit. Like if you see any P waves, and quite honestly, I think it's difficult to see P waves. There's a little irregularity in the cycle length that was most apparent in 1, 2, and 3. And that might be helpful if you saw P waves, if you thought you saw P waves. So in other words, if there's a long cycle, you ask yourself, is the V come first or the A come first? What guy moves first, the A or the V, the P or the QRS?
Unfortunately, the only clear thing that I can see as a P wave is here, and A comes before V.
Right.
But
and there's no fusion, there are no other clues.
Right.
So.
But then, if I were to assume that this is VT, and of course I will talk about the differentials as well, this is a right bundle morphology with, we have left superior axis, and I mean, of course all the inferior leads are negative, and we have negative waves V3 onwards. So
Right. So the paper with all those authors, it fulfills a lot of the criteria for V2, for VT. So it makes a lot of morphologic criteria for VT. So clean EKG, no AV dissociation. So why complex tachycardia with atypical right bundle branch block, right? Everyone sees that. Meets all the criteria for VT. This is, what is this? This is perfect RSR prime, okay? Perfect, typical right bundle branch block, typical for SVT, right? RSR prime, sharp upstroke, R over S greater than 1 in V6. So all the morphologic criteria, SVT with typical right bundle block aberrancy, burn it into your brain. This is, when you get this, it's golden, but you don't always get this. Now, I'm giving you the patient's baseline EKG. Remember, baseline EKG is really important. Try to get it. And now, side by side, we have the patient's baseline EKG and their 12-lead EKG compressed. Now, what do you think's going on? How does that change what you have to think?
now comparing to the baseline EKG, it does look like SVT with aberrancy, and so it's very important.
Yeah. So it brings home the point. Morphology are probabilistic. The only thing that's absolute is the AV dissociation, fusion beats, but you don't often get that.
Yeah.
And that when you can get it, and you got to try to get it, especially in the days of electronic medical record, the most recent 12-lead EKG helps tremendously. So, yeah. Atypical right bundle branch block at baseline. Always compare to your baseline EKG. This is a good slide to have. This again.
Can I ask you something?
Yes.
I'm with the fellow though. If I saw that and didn't have a baseline, I'm calling it VT.
Absolutely.
Yeah,
Absolutely. He did a great job.
Yeah, I was going to say, that's what I would call it.
Yeah.
I think the key that Ken is saying, make sure if you're an ER call to see someone like that, I'd probably do something about it. But I would make sure I get a 12 lead right away after, right? So, I think that's his message. But
Adenosine?
well, I can promise you if he was stable in our ER, he would have gotten adenosine.
Yeah, I think that's reasonable.
Yeah, and if that didn't work, he'd probably be started with IV amio. That's our ER, dude. God forbid anybody, wants to put a little juice across the chest. But I would have called it VT. In a million years, I'd call that VT.
And that's why I said it has an atypical right bundle. It meets all the morphologic criteria for VT. Probabilistic, look at the baseline 12-lead EKG and then put them side by side.
So Wellens used to say that V in V5 and 6, if it was negative, that means it has to be coming from there, the left ventricle, right? So this is very screwy right bundle.
Yes.
Well, if you go back, can we put it back one? So I'm with you on that, George. I was looking.
Oh, did I?
Where am I on the wrong end?
You went past it. Just go back one.
One more.
Go back one.
Hey, Dr. P, can you turn on
There,
your microphone?
there.
Let me do it. Here.
There you are, Eric.
Yeah, if I'm looking at this, honestly, R is upright, and AVR is upright, 2, 3, and F are down. V6 is less than one, ratio of less than R, less than 1. Those were the early Wellens criteria. You said if you had all three of those, you got VT. So I would have called it VT.
So if you go back to the I think I have a slide, or maybe you have a slide in one of your talks with the Wellens criteria. If you go back to them.
Yeah, I have that, but
None of them
they have
are
it in the book.
perfect. None of them are 100%.
I agree.
They're like 15 out of 16. So they're probabilistic. Okay, let's do another one. Who wants to do this one? Somebody from this table. Anybody, come on.
Now, you see, you can't be yelling at me now. He gave you a classic VT, and it was SVT. So you guys got to leave me alone. I always hear after the course, Prostowski, he sandbagged this. That's why George said, any day of the week, it's PVCs unless Eric's showing a slide. So it's like, just remember, he's worse.
All right, George Waits from Houston Methodist. Great to be here.
Good to have you.
So I've got a wide complex tachycardia. I am it's fairly regular throughout, and this does not seem to fit atypical. This is looking like an atypical right bundle morphology, maybe. And just looking for P waves, I see maybe something here that's not seen elsewhere. But
look at your rhythm strip. Look at your V5.
Could these be retrograde P waves?
So,
or these be retrograde P waves?
So in AVF, they look positive, but
look at V5.
Okay, looking
the
at
rhythm strip. Start the first couple of
V5.
beats. What do you see in the ST segment there?
So yeah, so over the first 3 beats, this notching becomes more prominent. So maybe the P wave, and then it.
You need to focus on that because that's the whole key to this slide.
Okay. Well, if it comes and goes, it would seem to be an AV dissociation type process.
I don't think it comes and goes. Tell me about the vector of that P wave.
Okay. All right. So looking at V5, it appears to be positive. And I think, if I'm looking at the P wave.
After the QRS, there's that little negative ditzel.
Okay. Okay. So you're thinking this negative ditzel.
Yeah.
Okay.
So
all right, then it would be going away from V5. Okay.
Yeah.
Okay.
So now you've boiled it down. If you've correctly identified that as a negative in V5 and it's going left to right, then there's only 2 things in the universe that this could be. One of them could be.
So you're saying the atrial activation going from left to right would either be sort of retrograde conduction over a left-sided pathway.
Yes, that's one of them. or help from his friends.
Some concomitant like left-sided ectopy.
Left-sided atrial tachycardia.
Okay.
With a long PR. Or alternatively, it could be VT, but then what would you have to say? You have to have VT plus what? Accessory pathway. So this is, in spite of its morphology, which is a little ugly, what does this have to be? What's your first choice? With humility, guys, you know. Since I blew 2 of the 3 of the previous ones, I have to be humble.
It's probably the first thing.
If it's VT, you have to postulate there's an accessory pathway, which you don't like. There's 2 things.
Yeah.
All right? But if it's an SVT with retrograde conduction over a pathway, then that sort of fits, right? So now you can say that could be orthodromic tachycardia with a bizarre aberrancy pattern over a left pathway retrograde, or it could be a pre-excited tachycardia where it's coming down one pathway and going up the other. All right? I think the key to Ken's wonderful slide is, in my view, it's an atypical pattern, but the key is you've identified nice P waves, and on that rhythm strip, they're going left to right. And that really narrows it down. You've only got a couple of universal possibilities, and you pick the one that's most probable, so you're not diagnosing 2 tachycardias.
Okay. So let's see how we do here. Okay. So here's the patient's baseline EKG.
Okay. Right, so.
Pretty normal.
Yes.
Now, this patient was in the cardiac surgical ICU, which I didn't tell you. And I knew I was doing this course, so I figured if I don't show at least one slide with the simplest thing you can do in the world when you have a tough tracing in a post-operative patient is hook up the atrial wires and record an EKG. And I'm going to show you another example of that later maybe if I get to it. But so what do you see here? The atrial epicardial wire is hooked up to V1. What do you see here?
Okay, good, because I didn't know how to understand V1 without, that's good to know. Okay.
Yeah.
All right, so we're seeing an atrial electrogram. So this,
Show us the atrial
this is the
electrogram.
V's, and these are the atrial electrograms
Okay.
here. And so now I see that there's 2-to-1 VA conduction or
Dissociated.
Or dissociation.
dissociation between those two.
So the VAs are dissociated. So
Yeah.
what is the lesson we learn is that as EP people, we often look at these things in the QRSs and think, oh, that's a retrograde P wave. That's easy. A lot of times what we think are P waves is actually part of a patient who has significant conduction system delay, and they have abnormal patterns of ventricular conduction, and that gives a fragmented QRS. And that fragmented QRS is sometimes felt to be a P wave. And I'll show you another tracing. We actually hooked up the A wires to V1 and the V wires to V5. And so now, again, just showing AV dissociation. So this patient had ventricular tachycardia.
Could you go back to your original ECG?
Yes, sir.
Thanks.
Sure.
So I was just kind of listening to discussion, not opining because I thought it was going very well, but I will tell you how many times I've made this mistake. And so I am very careful now never to call something a P wave unless I really see it. I mean, I can't even begin to tell you how many times with a broad QRS I've made this call and I thought I was being so brilliant, and only to find out that I was totally wrong. And you got them in the lab, and you're looking at it, and it looks just like that, and it's VA dissociation. So I've blown that too many times to put my nickel on the line. If it's like a broad kind of QRS, I'll just tell you, it's often just part of the QRS.
So part of Ken's nasty slide, the reason I put my foot in it is because that little ditzel there looks like it's beyond the QRS border. So it would have to almost be like a late potential. Huh? Okay. So in this particular case, the morphology was more.
Yeah, no, I listen, like I said, I've had to extract my shoe so many times I don't put it in my mouth anymore. So, no, I mean, Mark Josephson, God bless him, he was like that movie, you know, I See Dead People. You know, you ever seen that movie? Look at all blank faces. There's a wonderful movie called I See Dead People. Mark was on tons of my courses over the years, and I accused him once. I said, you see P waves. You see P waves with every tracing I have ever shown. And you struggle, you look at it and you say, I don't see it. And Mark says, yeah, it's there. Look in lead 1, Eric. And it's like, I don't see it, you know? So you see dead people. I've fallen into that trap. I'm just going to tell you, when it's wide and ugly, I have made that mistake so many times, I don't do it anymore. I heard the whole discussion. I thought this is very academic. It sounds interesting, but I don't know if that's a P wave. So that's why I was quiet, because I've just fallen into that quicksand too many times.
So I served as Ken's victim honorably.
Yeah. Hey, listen, I served it the first time. I'm looking at that tracing. I'm saying, what are you talking about? I agree with this guy. It's VT. So, you know, just remember, he's the worst. When you go home, you say, you know, Prostowski and Klein weren't so bad after all. It was all about Ken. So, no, these are good lessons, though. Well, I guarantee you, you're going to make the mistake again.
It's a tough one, and if you have the chance to record atrial activity, as we did in this case, then you can really do it without dragging the patient to the lab.
But you'd have probably had more history here, right? I mean,
well,
you would
if
have
I
known.
gave you the history, you would have done
No, but I mean, the poor guy wouldn't have been. He'd say, and you'd say, well, he has a big anterior infarct, or he has this. You go, okay, it's VT, you know. But you won't be all alone. But the teaching point is spot on. Wide, ugly QRS can have at the end stuff that doesn't. And what would have been very helpful for me and George if you had a 12 lead simultaneous, because often those things, George, in that lead, when you have all 12 leads, you'll see it fall somewhere in some QRS in some lead. It's kind of like, you know, right at the end, and then you say, oh, okay, it's not what I thought it was. But yeah, I'm glad you stepped into this one.
No, humility, Eric.
Yes, I showed that.
I've never made a mistake in my life.
That was one of the Feynman's points. We all need it.
All right. By the way, I want to do.
I thought your slide was ventricular bigeminy too.
Let me tell you, we didn't share slides, as you can see. We're just going this blind. I'm having a problem now because the ACC, I'm on the ECG unknown this year, and I want to take them blind. And I'm having the other panelists all say we want to see the slides in advance. I'm thinking, really? That is so lame. So I said, I don't care. If I get it wrong, I get it wrong. But I mean, it's an unknown ECG session. Shouldn't it be unknown? Shouldn't the faculty get unknown ECGs? Yeah, thank you.
Otherwise, it's rigged.
It is rigged. I already saw the responses. No, I want to see the slide. No, I want to see the slides. And I said, I don't care. Don't send them to me.
Some very famous people want to see the slides up front. You know that.
And we and I both know it. We'll leave them nameless. By the way, I have to make we're running over, but I don't mind that. George, I hope you're okay with this. It doesn't make sense to switch you two. So what I'm going to do is let you take it to 5. You start tomorrow morning. And you'll just start tomorrow morning and do yours.
Absolutely.
Are you okay with that? This way. Otherwise, we switch with 10 minutes. Doesn't make sense. So go ahead.
How do you do that? How do you do that?
I'm going to show a picture later.
Okay, great. Okay.
In fact, I'll promise to show the picture, but it's with another complex tracing, and I don't want to skip around if that's okay.
I hope you appreciate that I took the fall for you and I bid on his teaching point to save you.
And just as a historical mention, there's something called Lewis leads. Lewis leads are when you hook up the right arm and right leg to the second and fourth intercostal space, respectively. I just mention it because it's historically interesting. It was one of the earliest people to use the electrocardiogram. Sir Thomas Lewis from England developed it. It's a way to record better atrial activity. So here's a 12-lead electrocardiogram. A 12-lead electrocardiogram, a normal electrocardiogram, no tricks. This is a rhythm strip hooked up, right arm, right leg, V2 right here and fourth interspace, second, fourth, right interspace. The right heart is anterior, the left heart is posterior. So anything on this part of your chest is going to be anterior. And this is a Lewis lead. So here's a 12-lead EKG. Who can tell me what the rhythm is? Their arrows pointing to the P waves. This is a Lewis lead recording. Anyone? What's that rhythm?
How many arrows? How many QRSs?
Yeah, VT, AV dissociation.
Can I just make a comment that all you guys are good at echocardiography, right? You should be able to see atrial activity on a good echo, huh? So you're making a rhythm diagnosis, you bring in your echo machine, and they'll think that, well, what the hell, they're doing an echo now, it's an arrhythmia issue. But if you can satisfy yourself that you see atrial activity, you should be able to see AV dissociation on an echo, all right?
That's of historical importance these days because to do an echo, you have to put orders in. It's a huge.
How about the point of care echoes, though, huh?
And by the way, another point of history, Einthoven, who actually, as you know, developed the ECG, there's a wonderful book by Snellen that has the correspondence between Einthoven and Sir Thomas Lewis, who was one of the great, yeah, I have this book. I'll let you borrow it, keep it. And I read through it with just marveled at the collegiality. Now remember, Einthoven develops this, Sir Thomas Lewis is using it, and they're sending tracings back and forth. The first case of AFib is in this book, okay, in their correspondence. And Sir Thomas Lewis sends this letter to Einthoven that, I think this is atrial fib, what do you think? By all means, please be able to show it to people. I mean, it was like, are you kidding? Versus today where people are so secretive about everything. And there's this wonderful exchange between these two very prominent leaders in the field. But, and then at one point, Sir Thomas Lewis said, I think in the 1920s, he's learned everything he can about electrocardiography, he's moving on, or something like that. So, but anyway, I'll let you have the book, but Einthoven.
Somebody from that table, come on up.
Uh-oh. We're not talking about you, Babette. You can sit there. Why don't you bring Babette up?
Okay.
That's a good idea.
So SVT, VT, pacing, artifact, electrolyte abnormality.
Richard, any
tell us who
comments from the peanut gallery?
Tell us who you are.
Hey, I'm Nick Hill. I'm one of the EP fellows up at Leahy outside of Boston.
Great.
You want some calipers? Or you don't need them?
Sure.
You're taking one for the team, are you?
Always. All right. So standing back and looking at this, it's wide complex, tachycardic, maybe one little faster than 150. QRS negative in V1, positive V5, V6.
So left
axis.
bundleoid.
Left bundleoid, yep. Lead 1, can't really see what it's doing. I mean, it looks like it could be negative, but 2 is so big it's kind of covering it up. Let's see, what else? Inferior axis high to low, V1 is negative. We mentioned that with the left bundleoid. Looking for P waves. I don't see anything clear. Just in the rhythm strip in 2 and the T waves, it looks pretty consistent. Now, looking out, V5.
What was your conclusion from the morphology?
Haven't reached one yet. Still taking it all in.
Oh, I see. Maybe you should.
But I was just about to
finish that.
comment on that.
Yeah.
V5, V6 from the baseline all the way up to the peak, it's actually delayed.
That's a good observation.
And then V1 as well. The initial forces are slow, which skews me more towards VT. Same thing with in 2. There is some delay, I don't know, maybe 60, 80 milliseconds at minimum.
So if you see V1, V2, V3, the classical left bundle has a little very narrow positivity and V1, 2, 3, and a straight down from V1 to V3.
I was just going to mention that. It looks like we have very small R waves here.
But they're wide. A little wide.
And that would throw also in, is there a shelf there, or does it go straight down like George is saying? So I don't know if this works. So to build on what George is saying, is this go straight down, or is it not quite
No,
straight?
there's some notching in the R wave.
All right, perfect. So what do you think?
So I think this is, probabilistically speaking, VT.
Good.
So now, though, can I ask him another question? Sorry.
Of course.
But it's not very wide, is it?
I mean, it's wider than we're used to, but not the widest QRS like the last EKG.
So
and this could be septal.
Yeah, so put it all together, right. So
outflow tract tachycardia, possibly.
There you go. That's what I call it.
Not possibly, definitely, right? So everything you said about the morphologic criteria for left bundle branch block, the left bundle stuff isn't quite as good as the right bundle stuff, but you hit all the high points, right? A broad R wave initiation, more than 30 milliseconds. Takes a while to get to the nadir in V1, V2, more than 40 milliseconds. And particularly when it has that shelf or fractionated thing, it takes a while to go up in V5, V6. Upright in 2, 3 on AVF, so the same morphology in the inferior leads, right? So if it's upright in 2, 3 on AVF, it means it's coming from the top, going towards the feet. And how can AVR and AVL both be negative? How can you be going away from your right arm and your left arm? So the only way is to be at the center of the heart. And what's at the center of the heart is the outflow tract. It's the central structure.
But also, just the very fact that the axis is straight down is not really compatible with a left bundle, because if it's a left bundle, it's coming from the right ventricular apex, which is usually somewhat low to high, so it's not going to be straight down like it's a vertical axis.
Right.
That makes a lot of sense.
So just the physiology, as they said. Just go. So this is a foil. This is what a normal physiologic left bundle looks like. It's a QS or tiny RS in V1, V2 with a rapid downstroke. 1 AVL, V5, V6, monophasic R waves, no Q waves. Occasionally you can see some mid-QRS notching. And so
Wait, go back there. Look at V4. You happy with V4? I'm not particularly happy with V4.
You're not happy with V4?
Well, maybe
Yeah, I'm not
seeing
happy
it
with
through.
V4 either, but
I mean, it has a bunch of notching in it, no?
yes, but
So this, when you say this person has scars somewhere, I mean, why would you have notching unless there's some scars somewhere?
yes, but it meets all the other.
Oh, yeah, I'm not saying it's not
Yeah.
a left bundle, but
Right.
it goes back to George's point, a left bundle with maybe something else
Yeah,
going on. They
absolutely.
may have old MI or something like that. Usually you don't have notching in a pure left bundle, do you, Ken?
Right. No, you don't. But this was an SVT with left bundle.
Yeah. No, I believe what you're saying. I always worry when I see notching in a QRS.
Anywhere, fragmentation.
Yeah, fragmentation, yeah. Okay, go ahead.
So this is what Eric and George said. They said R wave, if it's too broad, it means it's VT. And in this paper, the broadness was defined as more than 30 milliseconds, so a little bit less than one box. The notching, as Eric pointed out about the notching, favors VT. And if you go from the onset to the nadir, if it's more than 70 milliseconds, I think actually it's more than 40 or 50 milliseconds, favors VT. This was an early paper. Mark Josephson looked at it again. It was 40 or 50 milliseconds. This is how to use lead AVR. Rather than memorizing this, you can think about this in terms of physiologic vectors, okay? AVR, again, relying on a single lead, but AVR, if you're going to get a right bundle delay, you're going to have delay here. So your vector in AVR for right bundle is going to be a QR. And for left bundle delay, the vector is going to be away from AVR, so it's going to be completely negative. And for apical VT in AVR, you're going to get a broad R wave. For basolateral VT, again, you're going towards the right ventricle, towards the right arm. So you're going to get a broad R wave. With inferior MIs and basal or basolateral VTs, you get a broad R wave. Or if you're very septal, you get a Q wave. Basal septal VTs will give you a Q wave. And RV VTs will actually give you a Q wave also. So QR for right bundle, QS for left bundle. And so this is how to use AVR. There's another criterion sometimes people use looking at the time from the onset of the R wave to the peak of the R wave in lead 2, if it's more than 50 milliseconds. I think the point is to look at the physiology. Every lead has its own parameters, and there are all these different criteria, but I think you should know the basic criteria and be able to use them in terms of the physiology of normal conduction. And you did a great job.
We don't want to confuse 2 points. Ken was actually talking about 2 things. In its simplistic thing, you're looking for the typicality of the right or left bundle, and you can do that in various leads. I have my favorites, as I showed you. But the other thing he was talking about was, you know it's VT, so where is it coming from? So localizing PVCs and where they're coming from, that's a different ball of wax. He knows that it's VT. Now he's asking himself, where is it coming from? And that's a different ballgame. It's, I think, a little more complicated.
Yes, no question. So let's do another EKG. Thank you. That was a great job.
Thank you so much.
Well done, by the way. Very nice.
Okay.
You're all doing very well.
Come on up from this table. Why don't we pick on someone here? 65-year-old man admitted with syncope during a marathon, and telemetry shows the following.
And tell us your name, where you're from.
Hey, so my name's Ballant. I'm from the Cleveland Clinic.
All right.
And let's see.
You're a third year also?
Third year general fellow,
And you're
yeah.
going into EP?
EP, yeah.
Good for you.
So narrow, wide complex tachycardia. What are you worried about anything? What do you want to do?
Yeah, so I mean, the consideration here is whether this is polymorphic VT. The other consideration is whether it's telemetry artifact.
Can I give you a Shakespearean quote? Would you like a quote? The Merchant of Venice. All that glitters is not gold.
So can I have a pair of calipers?
Yeah, yes.
Little education in here, just to give you a little education. Anybody read Shakespeare anymore? Do you all during your training? He's an English guy. Remember him? Stratford-on-Avon and all that. Yeah, 1600s. Been accused of plagiarism, you know. But we all think Shakespeare actually, they did actually a study. Can I just interrupt? Do you believe this? They actually looked one time, because there's a whole thing about, did Shakespeare really author all those plays? There's a whole literature on that. Somebody did this incredible computer program looking for words and syllables and on things he definitely did versus things that, some of the other playwrights of the day, and concluded it was definitely Shakespeare. The plays contained the same kind of wording and consonants and everything. Isn't that incredible? So we can't adjudicate it any better than that. So we'll just say Shakespeare did it. But okay, all that glitters is not gold.
Yeah, so I have a strong hunch this is artifact, but it's hard to prove it definitively. I mean,
what?
Maybe
what are you
not.
talking about?
Maybe.
Okay.
What? See, like this could.
Why are
be,
you starting there?
But not,
Why are you starting in the
over
middle of
here.
the storm?
Use your measured.
So yeah, like here.
Can I quote Miss Piggy?
Yeah, go ahead.
What?
What? No, wait. Why do you want to, listen, can I ask you something, just a practical question? If you weren't sure which way to turn, would you wait till you got into the middle of a storm and try to find the sign? Or would you maybe, like beforehand, want to see the sign that said, go here for right and go here for left? What do you think?
So
correct. Look on the left and then look on the right.
That's pretty
Yeah,
close.
so this is very suspicious.
Take more than
Keep
one.
on
in your
going.
Wait,
So
can I
don't
help
see-
him a little bit?
I mean,
No,
this as well, probably.
that slow down.
And
Go
then-
back.
Oh, good.
Can I give you a trick, or do you want to keep going? You
No,
just
go
want to. Okay. On these slides, never put one in your caliper. Do 2 or 3 intervals and see if they work. You know what I mean?
Oh, you mean like that?
Yeah. Just it's easier that way. See if they, because sometimes you'll find it a little easier that way.
Pretty damn close.
Yeah.
Oh
And
my
then
God!
that
Oh,
lines
look
up
at
good.
that.
There we go.
It's a miracle.
So you marched through this thing that marches out like a QRS. It interrupts the artifact. And the other trick or the other sign is when the baseline starts wandering. So you have both of those. This is an artifact.
So just to
George?
make one more point to add to Ken's, I call this the differential diagnosis of schmutz, all right? Which literally means crap, all right? I think, garbage. So there's the 3 telltale signs are, the first one is you can march the thing through it, but that's the hardest, huh? If you wait for that all the time, it's very specific, but it's not sensitive, right? Seeing wander of the baseline is relatively common. It's very useful. But I find the most useful thing is non-physiologic intervals, okay? So you take the 5th beat, all right? Take the 5th beat, 1, 2, 3, 4, 5. And then you see 2 QRSs, pseudo QRSs, side by side, huh? So what's the refractory period of that ventricle in that case?
So
It's about
way too
60
short.
milliseconds, which is okay if you're a rodent, but not if you're a human being, all right? So I find the best indicator of schmutz is non-physiologic intervals. It's almost universally present if you've got a long enough
Yeah, I would agree with George on that. But I will tell you, I measure everything. But if my eye catches 2 crazy intervals, I know it's artifact. Unless it's a rat, he's right. They can have 60 millisecond ERPs. But good. Don't jump, measure. If you're
Good
not
jump.
sure, measure. Because the differential here is a defibrillator or, forget about it.
Pat on the back.
We used to call these toothbrush arrhythmias, right? On the monitors, the nurses run into the room, the guy's there doing this, and his lead is going up and down, and they're running into the room, and, it's like, what's going on? And the guy said, what are you talking about? Just brushing my teeth, Toothbrush arrhythmias.
Or if you want to get everybody in an uproar when you're doing rounds and patients got these leads on, just go.
Yeah, that's right. That's also fun. Yeah, if you've called the nurse 2 or 3 times and they haven't come in, just and you'll see everybody come in. You go, oh, there you are. By the way, his IV is.
We are not
needs to be
recommending you
changed.
do that, though. Please, we're not advocating.
Yeah, don't make. That's right. Do not make an enemy of your call nurse, because I guess here's what will happen: 4 in the morning. Dr. Stowski, yes. Did you really write an order for Maalox? It's like, seriously? And then you realize the next day you did something that really ticked her off, and she's coming to get you. Don't ever do it. I tell my fellows when they start their new jobs at new places, I say, I don't care whatever else you do. First of all, you never piss off your partners. You never complain about, how come I get the last case? Okay? That's going to make you not popular when you're the new person on the block and everybody else has been there for years and you're complaining because you got the last case. And so the second thing you do is you just make nice with every nurse that you come into contact with. And I mean the floors, the EP nurses, right? Because you need them as your ally. I mean, it's the right thing to do anyway, but you don't want to make an enemy of the nurse. Trust me, it'll just, right? Am I right?
So when I was a resident...
Practical, powerful advice. And don't go into a job interview saying, now, exactly how many weekends will I be on call is your first question?
That's not a good first question. That's right.
So when I was a resident, just a very quick anecdote, I was a bit of a smart ass. I still probably am.
No, they didn't agree with you.
Okay. No.
You, George?
One day, I was up all night peeing, right? And what they had done was they put Lasix into my coffee. Somebody finked. Now today, this would be assault.
Yeah.
In those days, it would be, give him what he deserves.
All right, we'll get one more case in. I never actually, all the years I've known you, that's the first time I've actually heard that story.
Really? I thought you've heard all my anecdotes.
I've heard almost all of them. That's a new one on me. All right, one more case, and then we'll let everybody travel.
How about this one?
Yeah, get one you can do in about 7 or 8 minutes.
Yep. How about this one? Who wants to do this one? This is a good one because it teaches a point, and I think it's straightforward. Somebody volunteer. Please come up. That's great.
Now, you know what it is, right? It's 100%. So we don't know what his point is yet, by the way, but I know you know what it is.
Kara Stout. I'm a second-year general fellow at the University of Nebraska. Excited to be here. Thank you all.
University of Nebraska?
Yes.
Wow.
When I say Omaha, it's always a fun response.
Yeah, Nebraska.
The wealthiest man in the world lives there in Omaha.
Is John Windle still there?
He's my mentor.
Did you tell him his mentor Eric said hi?
Yes, sir.
I thought he was retiring. That's why I asked you. He told me
he is not. He stopped doing procedures many years ago, but clinically works.
He is a wonderful man, isn't he?
So much so. His bedside manner is
just the nicest guy in the world. Please give him my best.
Yes, sir, of course.
Papers with the Aberncy.
That's right. John did that paper with me. Wonderful guy. Yeah, wonderful guy.
Okay.
See, when you're old, you've trained everyone. So between the three of us, we've trained half of the people who don't ever claim to be trained by us. No, it's actually the fun part of having a career in academics. You bump into people all the time who are being trained by one of your trainees. It's just kind of fun. Anyway, go ahead.
Okay. So this is very nice as I'm seeing some potentially initial, let's see, so this is V1 down, and then my limb leads, where's my 1, 2? I guess these are 1, 2, and 3, just to look for what would be.
Oh, I'm so sorry. Yeah, no, that was my fault. Sorry.
So I'm looking to see, even before we go into arrhythmia, if we're potentially in sinus based upon POA morphology. It does look like they could potentially be upright, not biphasic in V1. And then looking up, I believe this is just 1. I think that I have potentially a biphasic P here. But I do have a QRS that follows everyone, inverted T. And looking...
What is your strategy when you look at something like this? What do you think?
I was looking to see if we were going from sinus and 2, and then I was going to approach these wider complexes and see if I thought that if we were
focusing on the transition is what he wants you
Yes, I was looking at the sinus, and I was going to look at the transition to see. Yes, sir?
That's a good thing. You have a philosophy. You have a plan. That's good. And I'll tell you, what is the easiest part of this tracing to look at? You've got 3 pieces. You've got something on the left, you've got a middle, and then you've got something on the long thing on the right. So if you had to frame Ken's problem, What are you asking yourself? What is the
Asking myself, is my
wide,
wide complex tachycardia, do I think it would be ventricular tachycardia
Perfect.
origin or something with an aberrancy?
And what is the most simple weapon that you have to look at for that wide QRS tachycardia?
So I think that I have.
Go to the left.
And
Go to the left.
It's not morphology.
Go to the left. Go to the left.
Go to the left. Okay, so
And we don't mean
I can
politically.
see
We're
that
not doing politics.
I can see that
I
in.
would never tell you to go to the left politically. But look to the left.
I can see that in V1, I start with an R, and I don't see a typical, any sort of left bundloid morphology.
Good.
But interestingly, when I.
So you got sinus rhythm,
Yes. And then.
something, and then something. You
Yes.
have P waves.
And I think that.
Why don't you look at the PP interval?
And I think that our P to P interval is. I don't actually see.
A little bit longer.
Right
yeah.
there.
And go to the right now.
And then. It's seemingly kind of actually hard to. If that is our. So there would be our P.
Okay, where's the next P?
And then our next P is somewhere potentially with maybe within that complex in this notch, and then potentially seeing here, it seems like there's a lot of baseline variation to tell if this is something that would be biphasic or not.
Okay.
But I don't see that the
So-
P's are marching with my QRSs.
How does that PR interval compare to that PR interval?
So I think that the PR interval is.
Look at it again. So the PR interval here, compare it against.
I think actually it looks similar with
Probably a little shorter.
maybe a bit shorter. And so if I have, and I don't have a regular R to R even from before, so if we've potentially shortened our PR interval and then go into some sort of a potential aberrancy, I don't know yet if I don't think that.
The PR interval shortens and you get aberrancy. Is it aberrancy or is it ventricular?
If my.
It's a lot shorter. And then there's no P wave in front of that beat, right?
Yes,
And
I
these two
think
beats
that.
look a lot alike.
So I
I
think,
think-
can I frame his question? He's kind of trying to lead you to the right path. Why would a PR interval suddenly shorten? Is there any physiologic reason why a PR would suddenly shorten?
If it was.
I mean, is it, I guess what he's saying is, how do you know it's really a PR?
Okay.
It's a P and an R, but what you're saying is the PR interval got shortened. Kenny's trying to lead you to a different road.
How about, can I lead you to a horse's ass approach? When I look, those guys are directing you to probably the more difficult part of the tracing, all right? The easy part of the tracing is all right on the right, all right?
Yes.
I'm rightward, I mean, not as far as some, but I mean, you know. So
We're
you've got a regular wide QRS tachycardia.
Yes.
What's the morphology of that tachycardia?
So
Is it right bundle or left bundle or what?
Looking
The
at-
wide QRS tachycardia. Now we're focusing on the wide.
Yes.
and because I looked at that first because that's the easiest thing for me to understand.
yes, sir. And I think
Regular?
it seems to be regular, the wide complex. I think that in V1 it looks like a more of a left bundloid morphology. Interestingly, it seems not complete concordance going down to V6, but I do think if I'm looking at V1, V2, I think that there's an initial delay in the R wave, so it would suggest more that it's not a typical left bundle morphology.
Not
so
typical.
More like VT per our
Perfect. That's a
discussion
VT
before.
morphology because
Yes, sir.
the nice left bundle that Ken showed you before had steep down
Yes.
in V1, 2, and 3. This is a steep down, so V1 was maybe okay, but V2, V3 is very unusual, and then you've got QSs right across the board, so it's almost even concordant.
Yes,
So,
excluding V3.
so what's the morphology on the right suggest to you? Which is probably right.
So I would think that in addition to that being potentially left bundle, what we're talking about, it looks like we have some notching on our downslope. Our time from the initial R
Good.
to the
Fair
this
enough.
Q is going to be, I think this is about 4 boxes. So I think we're over 100 or about 100 milliseconds. So I think those things would suggest towards VT.
It's a very VT morphology, all right?
Yes.
If you see that morphology without even measuring a thing, you'd have to say that would be very unusual. You're a little more confident when you look over to the narrow QRS parts because those QRSs are kind of narrow and sort of normal. So if you got a left bundle, you'd expect a normal looking left bundle. So Eric and Kent had a different strategy. My strategy was I recognize the stuff on the right as easy, low-lying fruit.
Yes.
So then I picked that and I say, Ken's looking at me like I really put my foot in it again.
No, you haven't. I mean, that's
a
fine.
VT morphology. Now I look at the left, and now I can, do some dovening on what's on the left. All right.
And can I add to what he's saying? I actually looked at the right, but I wanted her to go through it methodically. If you're doing fine, by the way. These are not simple cases. If you're going to make this aberrancy, it has to be a long short. There's no reason to suddenly have aberrancy, right? So is there a long short? I mean, this is a long interval, right? I mean, this is a real long interval. So it doesn't sort of fit aberrancy. The other thing is to look at the rest of the tracing. If you look at all of this, you have pathology here. This is not a normal ventricle, right? So you kind of know that. I don't know what's going on. I don't want to step in it either, but first of all, I'm looking at those T waves, and this is definitely not a normal ventricle, in my opinion. And then I see what George said, concordance, and it starts without a P wave, and you got a short PR, which is not conducted, and the QRSs of the PVCs look very similar to the rest.
Yes. These are PVCs, and they look just like the...
Right, so maybe I'm stepping in it too, but if that's not VT, then I'm treating Ken to a soda.
It's VT. You did great.
Oh, good. I saved some money.
The teaching point was if you see something that looks like a PVC and you see a Y complex tachycardia that looks like what you know is a PVC, because often you'll see PVCs followed by VT. It'll often have the same morphology. That's a give me. This patient, if you look closely...
cardiomyopathy?
Hold on. Look closely, you see a pacing spike here, right?
Yes.
So that tells you this patient has some ventricular pacing. These T waves are ventricular memory.
Oh, yeah, that makes sense.
Ventricular memory. And then
but the VT is real.
The VT is real. This is VT, teaching point, morphology for left bundle, PVC, identical to the VT. Then
I thought that was AFib at the beginning, Ken. I didn't see any great. It's totally
I was
regular.
struggling
The first 4 or
with
5
marking.
I
I was trying to struggle with
George,
marching those out.
When she's measuring P waves, I'm looking here and thinking, well, I guess my eyes are real old. I'm looking at this and I'm thinking, isn't this AFib? I mean, I actually thought it was AFib, and then I was going to say, there's no way in a million years this is
it is
SVT.
AFib. It is AFib.
Well, if it's AFib, it's 100%. Okay, look.
It's AFib.
I kept looking at this, and I'm thinking, I'm thinking, this is AFib. This is AFib, and what are you guys talking about? And she's measuring these, and I'm like,
I was trying to
can't
prove.
see crap. I mean, what are you talking? I said, well, maybe I'm looking at my glasses, and maybe my glasses are foggy. So, so if it's AFib,
yes,
and this is the baseline rate, in a million years you wouldn't suddenly go this fast and be regular. It would have to turn into flutter with some crazy mechanism or something. So I was looking at this. That was actually my first call. I thought, God, I missed sinus. I mean, I'm like, looks like fib.
I didn't want to
so
say
I'm looking at it,
either
I'm thinking, fib. I said, how the hell is this going to be anything but VT if that's fib? So basic point to take home: if you got fib, forget all the fancy stuff he showed you. I want to make life real easy. You got fib and it's going slow, you don't suddenly get a rapid wide complex tachycardia. 100% VT, 100%. I've never seen it fail.
And the
Is that
only
right,
thing I
George?
would add to that is whatever strategy you have, it's nice to have a strategy. My strategy is, boy, this is complicated. What piece do I think I understand the easiest?
Yes.
And I start there, and then I work to the others. You can start from the left, you start from the right, but usually transitionists are usually the toughest. It's often very useful. But if I see something that, for me, the wide course is a layup because it looks so bizarre that there's no way that that's aberrancy unless I put my foot in it like last time. So have a system. And we all have a slightly different system. But you start somewhere where you can understand is a good one to, and build on that.
But to build on George's point, you will see this all the time on telemetry strips, on Holter monitors, and when you have AFib as a baseline rhythm, it's not, you can't apply like you know, all the sort of things you can when it's sinus. So the biggest clue is when you see it suddenly go regular, there's really no reason for it to suddenly go regular. Or if you see it suddenly go fast. I mean, if you have all this slow stuff and then you suddenly see something 140 or 50 beats a minute and then you're back to slow stuff, there's no physiology in the world that could allow that to happen. So it's 100% VT. I mean, because often it's a monitor strip, right, Ken? And then you don't have the advantage of all 12 leads. But a basic rule, going to George's point, is if it's AFib and there's no reason for aberrancy and it's underlying rhythm 70, 80, 90 a minute and suddenly you're going 150 or 60, it's not. And that was a Pick and Langendorf rule. One of the rules of aberrancy during AFib, if you remember our course, George, one of the rules that I took away from that course was that if you're going to call something aberrancy, the underlying ventricular response has to be fast. And I never forgot that. I'm taking our notes with Clara. This is when George and I were just by ourselves. You weren't in Chicago. I'm sorry. That's George's wife. Just George and I slogging through the winter of Chicago. But I never forgot that rule, and it makes sense, right? Because as you learn more, I actually studied this in my own lab once. I put in all kinds of intervals trying to see if I can make aberrancy. But they were spot on, as they always were. That to get aberrancy, you have to have long short. And when the underlying rhythm isn't that fast, you just don't get long short. So you see the long shorts when the underlying rhythm is fast and suddenly you get a pause and boom, you're back and you get like run of wide. So that rule that they taught was really, really an excellent rule. So remember that.
In fact, that's what they said. If it's a relatively slow rhythm, think ectopy. If it's a fast rhythm, think aberrancy.
Yeah, it's a good rule. It's a good rule to remember. You did great. Give my regards to John, please. All right, so listen, what we're going to do, I'm going to let you finish up in a second, Ashita, but sorry? Your question. Oh, yeah, I'm sorry, go ahead.
I was just trying to localize the last VT, and I noticed there was a pattern break in the negative concordance in the precordial.
I'll tell you where it is. Okay. Where do you think it is? Is it left bundle or right bundle?
Well, it's left bundle, so
it's... What's the axis?
So, yes.
Where do you think it's coming from? Where? It's somewhere in the posterior area. I don't know if they had a heart.
If you go back to this slide,
yeah.
I think there was a pattern break in V2.
Yeah, that's what I was asking about.
Yeah, but
It's
2,
a
3, and F
pattern
is
break.
negative.
That pattern break is typical or pathognomonic for PVCs or VT coming typically from something that lies under V2. So think about where V2 is. Where is it? Exactly. Actually, AIV, the anterior interventricular.
No, not 2, 3, and F negative. I'm sorry, I'm not buying that. No. There's no, how can you have 2, 3, and F negative and AV septum? I mean, is that what you're saying? The septum, the summit, this wide in the summit? When have you seen a QRS that way? I'm sorry, I'm not buying that. Unless you're going to promise me that you put a catheter there and ablated this one, okay. I am personally not buying that. We all agree it's VT. I'm going to put my nickel on the fact if 2, 3, and F are down and it's wide, I think it's somewhere in the posterior set.
More
I think
apical, apical.
Or something, yeah. But it's all the V's are down, 2, 3, and F are upright. It's wide. It can't be totally septum unless there's a bunch of a disease, which there could be, right? That's probably a defibrillator, I'm guessing.
Right.
They're pacing with a defibrillator. So I'm going to respectfully disagree with my buddy, but at any rate, it's VT. You'll figure it out in the lab. Yes.
And I was thinking this is completely positive to that. So like the sum is the highest. So this is more consistent with Crocs, maybe distal Crocs.
Well,
This is
distal
also
Crocs
like
is proprioceptive.
Right, yeah, exactly. That would
You call it what you want.
And it's also like,
Yeah.
the inferior leads is like superior access and also QS morphology in 2. So that would
2, 3, and F down, you're going posterior to anterior.
That's true.
2, 3, and F upright, you're going anterior to posterior. It's not that hard, unless you have some funny congenital stuff that I know nothing about. But so I'm like a dummy when it comes to that, right? And all the V's down means it's electromotor forces are going from the left to the right. So place it somewhere. I place it. You want to place it in the Crocs, fine. I don't know exactly where it is. I know that if our guys were to go in there ablating, the approach would be to go into the right side first and look around that area. And you'll find it. I mean, just like with WPW, George and I spent our first 10 years of our career playing with WPW. And there's some patterns that you think you know where it is, right? Especially in that septal area, you go in, you're almost sure where it is, and it's not there, and, right? And it's 2 centimeters away. There's goofy things that happen, but I always tell people that I'll get you on the right street. I can't promise you the right house, but I'll definitely get you on the right street. I'm not going to put you, 3 blocks over. I'm pretty good at narrowing it down, but I'm not perfect, and I'm not going to go online. Anyway, here's what we're going to do. We're going to redo tomorrow's schedule a little bit. We're going to have George take the first tranche, and then I'll do a little bit after that. Then we'll get back on track. Since we want you to see like everyone's slides. You did a great job today. I can't believe how well you did. You deserve a hand. Thank you. And I'm going to. This is only because Clara's here, but. This is amazing that, I don't know how you got this guy down here, Claire. I'm going to give you all the credit. You have to understand, I went through back surgery this summer, and I know what it's like when you've just been through surgery. And when George said he was going to make the trip down, I thought he was out of his mind. Now, he may still be out of his mind, but he made the trip down. It's valuable to have a guy like George in the house, and I think we owe you a hand for your efforts. All right. Ashita, take over.
Could we please give a hand to our faculty? So just a few quick housekeeping notes. There is an agenda update. So regardless of what it says for location tomorrow, we're meeting for breakfast and lunch at King Arthur's Court, 3rd floor, executive elevator. So just a quick update. So that's where breakfast and lunch is. If you could take your calipers and your handouts with you today, because in case you come back tomorrow and it's not here or you sit somewhere else, just take those with you, please. We'll start breakfast tomorrow at 7 a.m. and the course will start right at 8, so please be there. And then as far as dinner, we have dinner today at 7 p.m. It's at the 32nd floor, executive tower elevators all the way up, and our team will be there with you. And then tomorrow, we'll meet in the lobby at 6:15 and walk over. It's just a quick walk. And if you're already out and about, take a picture, and I'll bring this up again tomorrow, but we can meet there then. So that's it for tonight. We'll wrap up and see you for dinner. Thanks. Bye.